A very good morning to all my friends there. How are you all? I welcome you to second day of our ophthalmology online class. I hope all of you have rested well and are now ready for continuing our journey of learning ophthalmology together. Welcome everyone to second day of ophthalmology class. Okay, so before we start with the the rest of the things, yesterday we discussed till the chapter of cornea, and there are few topics of cornea which we will continue today and then go ahead. I would like to clear few doubts there which I have got, and then we proceed ahead. Is it all right? Okay, so the first thing which I would like to discuss once more, one of our friend wanted to know about the Humphreys visual field chart once again. Okay, so let me show you the Humphreys visual field chart once again there. Here we are. So I showed you yesterday, this is the perimetry, the Humphreys perimetry test or the Humphreys visual field chart which we get. And if this kind of figure comes, and later on, as I told you, in the neuro-ophtha chapter also, we will be looking at some of the visual field charts. So when you get this kind of chart, what you have to look for is look at this part of the chart. Here, if you will notice, we call this as the grayscale presentation. Okay, it's called grayscale presentation. The areas which are appearing light in color, they are the normal areas of the visual field of that person. Okay, the areas which are appearing dark in color, that is dark black, they are the areas of scotoma. Right? So in this visual field, they are marking the scotomas here. So if this is the visual field, so in any visual field, as I told you, the central part. Now here, if you see, they will mention whether it is a right eye visual field or left eye visual field. So in this chart, it is your right eye visual field. So in the center of every visual field here, it will be your central fixation point. Central fixation point. Okay, and every normal visual field has a blind spot, as I told you yesterday. The blind spot is on the temporal side. So this temporal means outer. I told you yesterday the nasal side we call, which is towards the nose, that is the medial, and temporal side is the outer or lateral. Okay? So this is your blind spot. And blind spot is also scotoma. That's why it's appearing black in the chart. Okay. Now in this, if you see in the rest of the field, there are few more black areas. Okay, black shaded areas. So they are also scotomas. Like this whole area will be considered a scotoma. Okay. Similarly, these areas, the black shaded areas, they will be considered scotoma. So in this field, all these areas, the patient can have multiple scotomas. All these areas are your scotoma areas. So is it clear, my friend? Right? The central area is the fixation, central fixation. Then on the temporal side, there will be the blind spot, and the rest of the field can be normal in a normal person, or there can be some kind of scotoma as you are seeing here. Okay, is that all right? Right. So then another thing is, most of 2-3 of my friends, they had doubt about the perforation of a corneal ulcer in pseudomonas and how the organisms are going into an intact cornea. Okay, so I'll just tell you once more about this thing. I told you two things yesterday when we were discussing the chapter of corneal ulcer. Okay. When we were discussing corneal ulcer, see, listen to me once and then hopefully the things, they should be more clear. Now, in the beginning of the corneal ulcer, I told you for corneal ulcer to occur, okay, normal healthy cornea, all of us, we have cornea, but we are not getting ulcers. Okay. Every part of the body has normal bacteria on the surface. The skin has bacteria, but you don't get any skin infection all the time. The risk of skin infection is when you get injured, when the skin gets breached, then there is a risk of infection. Okay. Similarly, eye surface has also bacteria, and then there are bacteria around us, but we are not getting corneal ulcers. There has to be some predisposing factor. And for the corneal ulcer, the predisposing factor is epithelial injury. Epithelial injury, which I told you can be due to multiple reasons. It can be even like, you can rub your eye very vigorously and you can cause some epithelial injury, or it can be due to external trauma, or it can be due to certain conditions of the eye surface, severe dry eye, reduced corneal sensations, or anything. So initiating event is epithelial injury. Okay. So this is your cornea, and whenever there is epithelial injury, then what happens? The bacteria, they can enter the cornea and then cause corneal ulcer. Okay, so there is an epithelial injury. If it is healthy cornea, the bacteria cannot enter from this side, most of the bacteria. They need an area where there is an epithelial injury, then they enter the cornea and they cause ulcer. Now this ulcer can spread to whatever thickness of the cornea. When perforation occurs, when it separates throughout the cornea and this area gets sloughed off, then there is perforation. Perforation is a sequelae of corneal ulcer. Before perforation, the ulcer has to occur. And depending upon the severity, if there is lot of necrosis, then there are risk of perforation. Okay, so this I told you that Pseudomonas is one organism which can lead to the perforation because the severity of the ulcer is more in case of Pseudomonas. But the initial event has to be some epithelial injury, then infection of Pseudomonas occurs. It causes ulcer. The ulcer caused by Pseudomonas has high risk of perforation. Okay, but when I tell you that there are certain organisms which can pass through intact cornea. Okay, intact cornea means intact epithelium. They do not require any epithelial injury to penetrate the tissue and cause ulcer. For example, gonococcus. Now, gonococcus, what gonococcus can do, this epithelium is absolutely healthy, but still the organism can pass through epithelium, through a healthy epithelium, and cause ulcer. Okay, now this ulcer may or may not have perforation. That is a different thing. The thing is, this organism does not need an epithelial injury to cause infection. That is why when I was telling you about gonococcal conjunctivitis, see, conjunctivitis is so common, but not every conjunctivitis has a risk of infection in cornea. But gonococcus, because there is infection in conjunctiva, there is no corneal injury, but still it can cause ulceration of the cornea by entering through an intact epithelium. Okay, so I hope it is clear now, okay, that what I mean by the organisms which can pass through an intact epithelium. There are just few organisms, thankfully. most of the time you need an epithelial injury before any infection or ulcer occurs in cornea. Okay, friends, right? Okay, right. So after clearing these doubts, now we go ahead and we move on to from where we left yesterday. Okay, I'll just have to kind of scroll a bit here. Yeah. So friends, let's go back to our workbooks and the chapter of cornea, page number 65. Okay. So just like yesterday, please keep your highlighters ready to highlight the important points. Please keep your pens ready to add the notes where required. Keep on marking the things which I tell you as important, as questions, as image-based questions, as case scenario questions, because at the end, you will have all your hygiened points marked there. Okay, so please keep following me as I tell you that, and keep highlighting the important things. So where we finished yesterday, we have completed the corneal ulcers, different type of ulcers. Then we discussed about the diseases like keratoconus. Okay? So corneal dystrophies, we touched the important points, and now we are going to begin with corneal degenerations. I hope all of you are at page number 65, chapter cornea. Let's start with corneal degeneration. Okay? Now, corneal degenerations means that there are some degenerative changes in the cornea. There are few conditions which we need to know. Okay? And the first one we are going to discuss is arcus senilis. Arcus senilis. Okay? Arcus means like an arc, senile, age in, old age is senility or senile condition. Okay? So there is an arc-like deposition in the cornea. Okay, what kind of depositions? There is lipid deposition. Okay, the lipid tends to get deposited in the peripheral part of the cornea. Right? You see, now this cornea, if you notice carefully, this has got a whitish ring here. This has a whitish ring here in the peripheral area. And if you have noticed in most of the elderly people, even your grandparents at home, anybody you come across who is usually past the age of 60, 65, you will notice that their cornea has this whitish ring in the periphery. This whitish ring in the periphery, my friends, is because of with age, the lipid gets deposited on the peripheral part of the cornea, and that is known as arcus senilis. Okay? It starts from the superior and inferior parts, and then it makes a complete ring there. Okay? Now, this lipid deposition is the most common corneal degeneration. Most common corneal degeneration, and it is visually insignificant. It is not causing any vision problem. It is visually insignificant because it is in the peripheral part of the cornea. The central area is clear, so it is not causing any vision problem. All right, friends, right? Arcus senilis. So just the thing you have to remember is, what is arcus senilis? The lipid deposition in the peripheral part of cornea, and it is visually insignificant. Then there is another condition called arcus juvenalis. So juvenalis means, you can understand, then when this kind of lipid deposition occurs in younger age group. Okay, when it occurs in younger age group, in younger age, it occurs when a person has hyperlipidemia. There are certain hereditary hyperlipidemic conditions. So in that case, the person will have this lipid deposition even at a younger age. In older age, arcus senilis does not mean that there is a hyperlipidemia. Even in people with normal lipid levels, the arcus senilis can occur. It is an age-related change, you can say. But if it is in younger age group, then it happens because the person has hyperlipidemia. Okay, friends, right? But even then it is visually insignificant because it is only in the peripheral part. Now coming to another corneal degeneration, what we call as band-shaped keratopathy. Band-shaped keratopathy. So band shape means like a band. Okay? So there is a degeneration in a band-shaped manner in the cornea. Okay, as you are seeing here, you see this band shape, the central area, upper and the lower areas are fine, but there is this band-shaped opacity here. Why it is happening? It is happening because of calcium deposition in cornea. Because of calcium deposition in cornea. And why calcium deposition is occurring? The band-shaped keratopathy occurs in certain specific conditions. The causes of band-shaped keratopathy are, I have written here, uveitis in JRA. Uveitis in JRA. JRA means juvenile rheumatoid arthritis. Juvenile rheumatoid arthritis. So uveitis is inflammation of the uveal tissue. So in juvenile rheumatoid arthritis, the patients, they suffer from chronic uveitis and the cornea can develop band-shaped keratopathy. Okay. Similarly, any chronic inflammatory condition, okay, any chronic inflammatory condition, for example, chronic uveitis, otherwise also, not only in JRA, any person who has chronic uveitis can develop band-shaped keratopathy. Then there is a condition we call as phthisis bulbi. Phthisis bulbi. What the phthisis bulbi means? Phthisis bulbi means the eye globe, that is eyeball, shrinks in size. This is like, when eye is so much damaged that the whole eyeball structures, they are degenerating and eyeball becomes smaller in size, shrunken in size. We call it as phthisis bulbi. So in those conditions also, there is this band-shaped keratopathy. Okay. Then it can occur due to silicone oil. Silicone oil-induced keratopathy. Okay. Now, silicone oil is used in retina surgeries. Now, silicone oil is used in retina surgeries. Now, in these conditions, again, if there is complication related to silicone oil, it can cause band-shaped keratopathy. And then if a person is suffering from any condition leading to hypercalcemia, the blood calcium levels are more, for example, in multiple myeloma, the patients of hyperparathyroidism, lot of conditions are there in which the patient suffers from hypercalcemia. In those cases, the cornea can develop band-shaped keratopathy. Okay, and as you can see, since this deposition is in the center, so it will cause vision problem to the patient because it is blocking the central area. The patient will have vision problem. So you need to treat it. How do we treat it? You control the condition which is causing the band-shaped keratopathy, the underlying cause you try to control. At the same time, you can remove these calcium deposits by using a chelating agent like Adeta. So, Adeta is a chelating agent for calcium. So you apply, you scrape the cornea and you apply EDTA, and these calcium deposits, they get dissolved. So chelation with EDTA. Okay. And the second thing is, what you can do is a procedure which is called phototherapeutic keratectomy. Okay. In short, we also call it as PTK. See, look at the word to understand what is phototherapeutic keratectomy. Keratectomy, you know, ectomy anywhere in the body, the procedure means you are removing a part of something. Okay, so you are removing a part of the cornea, keratectomy. How? Phototherapeutic, using the laser. Here we use excimer laser. We are using excimer laser, and that laser helps in removing the area of the cornea, the part of it, not whole of it, just the superficial, because these deposits are usually superficial. The superficial part gets ablated by excimer laser. Okay, and then the healthy tissue will regrow. So that you can do. And in the cases in which there are deep deposits, then you do lamellar keratoplasty. So keratoplasty means corneal transplantation. We are going to discuss keratoplasty shortly. Okay, lamellar keratoplasty. Okay, so these three treatments are there for band-shaped keratopathy. Now, both these beta images can be shown in exam. So this image is of arcus sinalis. This can come as an image question. Please write it down. Just simple. How will you identify? There is, so as you can see, everything is normal except there is a whitish ring in the periphery. Okay, and band-shaped keratopathy can be shown as an image-based question. Image question. So how will you identify? You see there is this whitish band. There is this whitish band in the center. Not very difficult to identify band-shaped keratopathy. Okay, right? Right. So next we come to, like, you know, cornea. In cornea, the different deposits, they can be there. So we talked about the lipid, calcium, and then already we talked about the iron deposits in the cornea in two conditions. So yesterday we discussed keratoconus, and if you remember, we spoke about the iron deposit in case of keratoconus in the form of Fleischer ring. Okay, that was one of the clinical signs in keratoconus. So iron deposit in the case of keratoconus is in the form of Fleischer ring. And similarly, I told you the iron deposits in front of the pterygium head, which is called Stalker's line. So these, they can come as one-liner questions. Both of these are the Fleischer ring and Stalker's line. They are iron deposits. So this can come as one-liner questions. Fleischer ring is seen in keratoconus. Stalker's line is seen in pterygium. Okay. Then there is another deposit which is seen in the cornea, and that is called Kayser-Fleischer ring. Kayser-Fleischer ring, or in short, we call it as KF ring. Now, KF ring is due to copper deposition in the cornea. Copper deposition in the cornea. And it is commonly seen in a condition known as Wilson's disease. Now, this question has come 2-3 times in the exam. So please mark it as an important question. Kayser-Fleischer ring in Wilson's disease. Okay, now please listen here carefully. This Kayser-Fleischer ring is what? It is copper deposition which occurs. It occurs in two conditions. One is known as Wilson's disease. The second is known as chalcosis. Chalcosis is when some copper foreign body, please write it down, some copper foreign body is in the eye. eye can get trauma, and sometimes some foreign bodies, the metallic foreign bodies, they remain inside the eye. They are undiagnosed, or the patient did not go for treatment. So those metallic foreign bodies, they can keep on releasing the metal in the eye. So if there is a copper foreign body which remained in the eye and it was not removed, the copper gradually releases from that foreign body and gets deposited in the different eye tissues. So in the cornea, it can cause Kayser-Fleischer ring. Okay, the condition is known as chalcosis. So this I'm just telling you for your understanding why the chalcosis occur. Okay, but more commonly you will be asked the KF ring is present in which disease. So the name of the condition is Wilson's disease. And you must have done in your medicine, Wilson's disease is a hepatolenticular disease, that it involves the liver. It also involves the neurological manifestations, the brainstem manifestations. The patient has involuntary movements, chorea-like movements. Okay. So in the eye, the very specific sign of Wilson's disease is there, which is known as KF ring. So you see this yellowish, greenish ring, yellowish, brownish, greenish ring. Okay, this ring which is on the peripheral part again, but here it is yellowish, brownish, greenish kind of ring. So this is your KF ring. Now this can also come an image question. They can ask you a case scenario that there is a patient who is having hepatic involvement and the patient is having involuntary movements of the body. What will you see in the eye of this patient? So that is the KF ring. Okay, so I'm clear. Then early KF ring may not be visible, like this as we are seeing. Then we do a test called gonioscopy. So I'm going to tell you about gonioscopy in the glaucoma chapter, but here you please remember that gonioscopy is the best method for early KF ring. When the KF ring is not that well defined, very early changes are there, you can see it with the help of gonioscopy. Okay, then one more point here, please add. The question is, all the patients of Wilson's disease have KF ring? The answer is no. It is not necessary that all the patients of Wilson's disease will have KF ring. Okay, so Wilson's disease, please write here, because there was a question related to this in the NEET PG. So we should be ready for our exam also, that if such a question comes. Now in Wilson's disease, the patients with neurological involvement, the patient who also have neurological involvement, 90% will have KF ring in the eye. So actually the patient is sent to the eye OPD to look for KF ring. And if you find KF ring, that goes in favor of diagnosis of Wilson's disease. So the patients of Wilson disease with neurological involvement, 90% have KF ring. Okay. And the people who do not have neurological involvement, only hepatic involvement, the patients with only hepatic involvement, 50% they have KF ring. Okay, so please remember this point here, that not all patients of Wilson's disease will have KF ring. It's more common when it is neurological involvement also there. If the patient has only hepatic involvement, only 50% of them are going to have KF ring. Okay. Now, a simple thing to remember, sometime you can get confused about Fleischer ring and Kayser-Fleischer ring. So please do not get confused, dear friends. I'm going to mention here Fleischer. You can also even write here, Fleischer is iron ring. Fleischer is iron. What is the chemical symbol of iron? Anybody liking chemistry there? The chemical symbol of the iron is Fe. So remember, F for Fleischer, Fe for iron. Okay. And then Kf ring. Kf ring is Kaiser-Fleischer and copper. So if you think of Hindi, so Kaiser, copper, not Kiran, Kaiser, copper. Okay, so this you can remember. Kaiser means copper deposition, copper ring. Fleischer, F, ferrous, iron. Fleischer, ferrous, copper, Kf. Okay, so that way you will not confuse which deposition is there. Okay, so please remember the KF ring, Wilson's disease question, image-based question, clinical case question has come in the past, can come in the future. Okay. Then in the corneal depositions, another thing is a condition, come down beta, called cornea verticillata. Cornea verticillata. It is also known as vortex keratopathy. Vortex keratopathy. So in this, there are deposits in the cornea in whirl-like pattern, just like a whirl, as you are seeing here, whirl-like pattern, like this. Okay. Now, this kind of deposits, they can occur due to certain drugs, and they are also seen in a condition known as Fabry's disease. Okay. So please remember the condition cornea verticillata, also known as vortex keratopathy. So in this condition, you can be, again, it can show up as a image-based question or a case scenario. I'll tell you what kind of case scenario. Okay. So first of all, look at the list of the causes. So many drugs, for example, chloroquine, amiodarone, endomethacin, add two more here, tamoxifen and chlorpromazine. Tamoxifen and chlorpromazine, and then a disease by the name of Fabry's disease, they can all cause this kind of deposition in the cornea. Okay, so how the question can come? So remember the name of the drugs which can cause cornea verticillata or vortex keratopathy. They can ask you about the drug. They can tell you a condition, like for example, with chloroquine, it is very common. Okay, so please mark a star with the chloroquine. It is very common with chloroquine. So the question will be, chloroquine is mostly used in patients of rheumatoid arthritis. You know, rheumatoid arthritis, many patients you will see, they are treated with chloroquine. So how the question will come, that a patient who was suffering from rheumatoid arthritis and on the medication for it shows these kind of changes in the cornea. So what is the condition or what is the drug responsible? Okay, so they can give you an image also, or they can just give you a hint that it shows depositions in the cornea. Okay, so then you have to think that they are talking about vortex keratopathy or the chloroquine toxicity. It's a chloroquine toxicity, the vortex keratopathy. And you can write here the chloroquine can cause two changes in the eye. Please mention here. One is your bull's eye maculopathy. That is the toxicity in the retina. Bull's eye maculopathy, and as I told you, vortex keratopathy. Okay, please write it down to your friends. So this question has been coming chloroquine related. So condition will be the patient of rheumatoid arthritis on long-term chloroquine therapy. What can happen in the eye? Bull's eye maculopathy and vortex keratopathy. Are we all right here? So these are the important conditions in which different deposits you see in the cornea, and they can ask you questions based upon that. So what we did, vortex keratopathy, don't forget, KF ring, Stocker line, Fleischer ring, band-shaped keratopathy, arcus senilis. So these are the things which are important for the exam, friends. Okay, so have you written this there? Okay. Now, let's come to the last topic which we need to discuss in the chapter of cornea. Moving on to the next page, beta. Keratoplasty. Keratoplasty. Right. So what is keratoplasty? You can commonly call it as corneal transplantation. Okay. Now, cornea is one of the tissue in the body which can be transplanted, and it is one of the most successfully transplanted tissue in the body, because the acceptance of the graft by the body is very, very high. Okay, so keratoplasty means corneal transplantation. We call it as allograft because the graft is given by a donor. Okay, and you replace the diseased cornea of the host, that is the patient, by a healthy graft. So it's an allograft, the graft from somebody else, and the donor is always a cadaveric donor. So you must have seen, like, so many movies, they show that there is this lover who donates the eyes for their beloved out of love, and they themselves become blind, and their beloved becomes okay. So that is not the reality. You cannot take the cornea of a healthy person. That's all bullshit they show in the movies. So it's always a cadaveric donor. That is, the cornea is harvested from the person who has, died. It is taken from them and then transplanted to a live host. Okay. Now, keratoplasty, when we need to do the corneal transplantation, there can be various indications, various you can say types or purposes when we are doing the corneal transplantation. Okay, so in many diseases which we discussed, I spoke about keratoplasty. So there are 3 reasons when I have to do the keratoplasty. Okay, so I might need to do the keratoplasty for optical purposes, when I want to restore the vision of the patient. Okay? So when do we restore the vision of the patient? When the cornea has become scarred. Okay, the cornea has become scarred. For example, due to corneal ulcer, ulcer has healed, but the cornea has become scarred. Similarly, we talked about keratoconus, in which there can be scarring in the advanced stages. Corneal dystrophies, we talk about the stromal dystrophies, endothelial dystrophies. So here the cornea has become opaque, and I need a clear graft so that the patient can now see again. Okay, so this type of the keratoplasty is known as optical keratoplasty, and the purpose is to restore vision. Right? Then the second purpose can be tectonic. Tectonic means where you are putting a graft to support the cornea mechanically, to provide a mechanical support. For example, the cornea has become thin or perforated. We talked about the perforated corneal ulcer. So for example, in cases when the ulcer in a stage of dysmetocele, it is about to perforate, or there is already a large perforation. If I do not support the cornea, there will be irreversible damage to the eye. So that time the graft we use, that is called tectonic graft. So you can write here, the purpose is mechanical support to the cornea. Mechanical support right? And the third purpose can be what we call as therapeutic. Therapeutic means like there can be sometime corneal ulcer which is causing so much necrosis and it is not getting controlled by the treatment also. Okay, so just like you can imagine, like if there is abscess in the body, sometimes the antibiotics alone do not help. You have to drain the abscess. But in cornea, you cannot drain the cornea. You have to replace it by something. Okay, so what you do, you remove that cornea which is having ulcer and you put a graft. So then we call it as therapeutic. Okay, because you are removing the diseased cornea which is having the ulcer and you are putting a healthy graft. So these can be three purposes. Okay, so then we give this name to the keratoplasty, that you are doing an optical keratoplasty, you are doing for tectonic purpose, or you are doing for therapeutic purpose. Okay? So you are replacing the diseased cornea by a healthy graft. Fine. Now, the point to be remembered about taking the graft, the donor cornea should be harvested ideally within 6 hours of death. Okay. So when a person dies and they want to donate cornea, so ideally the cornea should be harvested from the donor within 6 hours of death and maximum up to 12 hours. Okay. That is when the graft will remain in healthy condition. Okay. Then the keratoplasty can be divided into, the procedure can be divided into two types. One is known as penetrating keratoplasty. Penetrating keratoplasty means you are using a full thickness graft. Okay. So first of all, listen to me and you will get to know what I'm saying. Penetrating keratoplasty means full thickness graft, that whole of the corneal tissue is replaced. Okay. The second type is lamellar, in which we can partial thickness graft can be done. Partial thickness graft can be done. Okay. Now, when I talk about the partial thickness graft, the partial thickness graft can further be divided into anterior lamella, posterior lamella. Okay, you can replace the anterior part of the cornea, you can replace the posterior part of cornea. Okay, anterior part means epithelium, Bowman membrane, stroma. Okay, but you leave the descemet membrane and endothelium behind. The host descemet membrane and endothelium remains, only anterior part, stroma, Bowman membrane and epithelium are replaced. Okay. The second type can be posterior lamellar, which will be done in endothelial diseases. Here you replace only the descemet or endothelium, only descemet or endothelium. Okay. So you can partial, you can do the anterior part, you can do the posterior part. Okay. Similarly, so here make a correction, friends. It is not automated. It is anterior only. Make a correction here. It is not automated. It is anterior. In anterior lamellar keratoplasty, in short, we call it as ALK. It can also be superficial or deep. How much thickness of the cornea you are replacing, whether just the superficial thickness or very deep in the stroma. Okay, so once again, when you are replacing the graft or when you are transplanting the cornea, you can do it penetrating, that is full thickness. Full thickness means the whole thickness of the cornea is replaced. Okay, or you can do partial thickness. In partial thickness, you can replace the anterior layers or you can replace the posterior layers. Okay? In anterior layers, it can be just the superficial part or very deep in the stroma. So these are the terminologies which we use depending upon which graft we are using. Okay, so let me show you a figure. You will understand this better. So this figure, if you come to the next page, that will help you understand this better. So please follow me in this figure here. So if you see here, friends, so this is like, cornea, the epithelium, Bowman, descemet, and endothelium. Okay, this middle part is stroma, right? Now, if you are using, look here, you are replacing whole thickness of the cornea. So when you are replacing whole thickness of the cornea, it is penetrating keratoplasty. Okay. Then in lamellar, it can be anterior lamella. Okay. Come to this figure C. You see here, endothelium and descemet, they are not replaced. They are not replaced. This is not being replaced. Only stroma, Bowman, and epithelium. This part is replaced. Now, this is example of deep lamellar. If I had replaced only maybe this much part, if I had replaced only maybe this much part, that will be superficial anterior lamellar. Okay, so depending upon how much depth you are replacing. Okay. Then if you are not replacing the anterior, see here anterior is the same of the patient, but you are replacing descemet and endothelium. So this is posterior lamellar. And even in posterior lamellar, if you want to know, you can replace both descemet and endothelium like here, or even only endothelium. So surgically, so advanced these things are. Okay. So partial thickness means you can replace any layer, only endothelium, descemet and endothelium. Okay. The superficial layers, whatever depth of the stroma you want, right? And you can just ask me, just for your knowledge, why do we do lamellar? Why not do full thickness for every patient? Because when you are doing lamellar, one graft can be used for 2 patients. Corneal graft, to get a donor is not an easy thing. If you speak to the people who are there, the people, they are waiting for the graft. There are waiting list. So if you get one healthy cornea, one donor, and you can treat 2 patients, one patient who is requiring anterior lamellar, one patient who is requiring posterior lamellar. So you can treat 2 patients. So that is why, if it is possible to do lamellar keratoplasty, we go for lamellar. But yes, in the condition in which whole of the cornea is damaged or scarred, we go for penetrating keratoplasty. That is full thickness. Okay. Isn't it interesting? Okay. Now, another important thing for your exam, which you need to know about the corneal transplant. So there is this space there below this figure to write down something about the corneal harvesting. Corneal harvesting means how you are taking the graft from the donor. Okay, so please write it with me. Corneal harvesting. Corneal harvesting. So taking the graft from the donor. You can write it. What does it mean? Taking the graft from donor. So when you do corneal harvesting, we can remove the whole globe of the donor. That whole of the eyeball is enucleated, removed, and then the corneal button is removed. Okay, so you can take the whole globe from the donor, or you can remove only the corneal button from the donor. Okay, right? Then, as I told you, ideally it should be done within 6 hours of death, but up to 12 hours of death, you can take the graft from the donor. Okay? Then how the preservation is done? how the preservation of the graft is done. Okay, so it is not that you you just got the graft and immediately you are putting it or doing surgery on the patient. So it has to be preserved in proper manner. If you require short term preservation, short term, just that within few hours you are going to use the graft, we do the preservation in moist chamber. These points, they can be asked in the exam beta. The moist chamber at 4 degrees centigrade is used to preserve the graft. And if it is intermediate, that it's going to take some more time there. So the intermediate preservation is done in a special media, which is called MK media. So these can be asked as questions. So remember them. Short-term preservation can be done in moist chamber at 4 degrees centigrade. Intermediate preservation is done in special medium called MK medium. Okay. And then in the last, the thing which you need to know, the contraindications of corneal donation. Now, what are the cases in which you will not accept the corneal donation? Okay, there are few conditions. If the donor had certain infections, which infections? HIV, hepatitis B, rabies, or the death was due to septicemia. Okay, so in these conditions, if the patient had HIV, hepatitis B, rabies, or the death was due to septicemia, you will not accept the donation. Okay, then certain malignancies. Which malignancy? Any head and neck malignancy, or intraocular, that is within the eye, intraocular malignancy. If the patient suffered from head and neck malignancy or intraocular malignancy, we do not accept the donation. Okay. If there was prion disease, and lastly, death due to unknown reason. So these are the few contraindications to corneal donation. So in these cases, we do not use the cornea, we do not accept the corneal donation. Okay, so these are the things. Please write it down. Infections, malignancy, which infections I have mentioned, malignancy, prion disease, and death due to unknown cause. So the questions, they can be asked, as I told you, the indications of keratoplasty I have mentioned in the beginning, how to preserve, types of keratoplasty, and contraindications. So with this, we have finished the chapter of cornea. And I hope I posted few questions yesterday based upon what we did in the yesterday class on the Telegram. So that must have given you some idea that how to attempt these questions, how to revise your subject so that you are able to attempt those questions. Did you do that, friends? Many of you had done that. So that's very good. So there are some questions at the end of the chapter in the workbook also. Okay, so let's do them also, and then we move on to our next topic. We are done with the chapter of cornea. So cornea, as you know, had many important topics for your exam. Corneal ulcer, especially fungal, viral, don't forget them. Acanthamoeba, then keratoconus, very important topic. Okay, then corneal degenerations, you can get the question. Okay. So all these questions, they can be very important. So these high yield topics are a must for the exam. They're must for the exam. Okay, fine. So coming to the workbook questions that will help us in revising the cornea. So coming to the first workbook question, a very simple one, most metabolically active layer of cornea. So even this topic is important, but are questions based upon the different layers of the cornea. So I told you most metabolically active layer of the cornea is endothelium. It has that sodium potassium ATPase pump, which helps keeping the cornea clear. The most common cause of corneal perforation in a rapidly progressive ulcer. So just one organism you have to remember, Pseudomonas. Pseudomonas can cause perforation very rapidly once there is already an ulcer there. Okay. Now then this question, please concentrate here on question number 3, because people do get sometimes confused here. Let me read the question and tell you the answer. Most common infection after soft contact lens use. Okay. So like, the people who regularly use soft contact lens and they are not, doing it with the proper hygiene and care, they are prone to develop corneal ulcer. Now, the most common organism or infection in these cases is again Pseudomonas. Now, Acanthamoeba is also common in soft contact lens user. Okay, Acanthamoeba is also common, but most common is Pseudomonas. So please don't confuse here, because sometimes you say, ma'am, you told Acanthamoeba soft contact lens use is a risk factor and the ring ulcer develops. Yes, it develops. But when we talk about the most common infection, that is Pseudomonas. Okay, so please don't get confused here. If the question is about most common, then it is Pseudomonas. If in the case history, there is history of soft contact lens use and other features related to Acanthamoeba, as I told you yesterday, very painful ulcer, ring ulcer, then you mark the answer as Acanthamoeba. Okay? So hope I am clear here. Fine, right. Then coming to the next question, all of the following are the clinical signs of keratoconus except. So remember, I told you the keratoconus signs are very important and the question can come based upon that. So all of our following are the signs of keratoconus except. Now, when you do these kind of questions, beta, please concentrate on except, because sometimes we do not look at that except and we tend to mark the wrong answer. So read the question statement very carefully. All of them are true except. All of them are false except, which is not seen, which is seen. So try to understand what the question is asking. So here they are asking signs of keratoconus except. So what do you think? Vogue stria are present in the keratoconus? Yes. Kayser-Fleischer ring is present in the keratoconus? No. It is the Fleischer ring which is present. Rizzuti sign present? Yes. Munson sign present? Yes. Okay. So this will be the answer here, that Kayser-Fleischer ring is not seen in keratoconus. It is seen in Wilson disease. Very good. It is seen in Wilson disease. Which ring we see in keratoconus? Fleischer ring. Fleischer. F, iron, Fleischer, keratoconus. Okay. Then another question, I had put a case scenario here. So look at this question. Let's read the case statement. A 30-year-old farmer comes with pain, watering, decreased vision. Okay, so when attempting these kind of case scenario questions, now listen carefully, beta. Try to find the keywords in the case statement. It is very important. Try to find the keywords. So keywords means farmer. So what type of the patient is? Farmer. Okay. What is the symptom that the patient is having? Pain, watering, decreased vision. So this is there. So there is painful eye, there is watering, the vision is also decreased. Then what is important in the history? Following injury with a twig. So history of trauma. This is another key point. Twig, vegetative matter. Twig means small branch. So it is an injury with vegetative matter. So something rings in your mind. Farmer, injury with vegetative matter. My brain will think about the fungal corneal ulcer. Fungal corneal ulcer. Then let's see what they are talking about. On examination, there is a corneal ulcer. So they have already told us that there is a corneal ulcer with elevated margins, satellite lesions. So satellite lesion, again, the bell should ring in your mind. Satellite lesion, fungal. So with the patient, the profession, with the history of trauma, with the satellite lesion ulcer, I already know that this is most likely a cause of fungal ulcer. So they can ask you directly this question also, that which type of the organism is involved. Here they are specifically talking about the name of the organism. What is the most likely causative organism in this case? They have asked about Pseudomonas. No, Pseudomonas is a bacteria. So I am suspecting fungus. So this is not the right answer. Aspergillus, yes, Aspergillus is the fungus. Acanthamoeba is a protozoa. Herpes simplex is a virus. So my right answer will be Aspergillus. The question choices can be bacterial keratitis, fungal keratitis, acanthamoeba keratitis, viral keratitis. Then what you will mark? Fungal keratitis. Okay, so this type of question has been coming so frequently, you must know how to attempt the corneal ulcer question. And I think you should not be having any doubt. If you still have doubt, you can ask me on the Telegram or mail or anything, but please make sure that if such kind of question comes, you mark it correct in your exams. Okay, right, friends? Right. So here we finish cornea. Here we finish even the workbook questions of cornea. I'll be putting more questions on the Telegram for you to revise. You'll be having your test and everything so that you are fully prepared how to go in your exams. Okay, right? Okay, friends. So next we have to move. We are going to do a very small topic, the sclera. In the sclera, not much is to be done. All the important topics which are to be done, I will be finishing that and then going ahead. Okay, so come to the chapter of sclera, dear friends. Sclera. So are you there with me? Can we start with sclera? Now, sclera, as we discussed in the anatomy, is again the part of the outer fibrous coat. Okay, it is the opaque part, the interior part, cornea we discussed. Now the rest of the outer fibrous coat is made up of sclera. So sclera, as you can see, it is a white opaque tissue. It is a white opaque tissue. Now sclera, this tissue is not like, bare. It is not bare. Sclera is covered by two more layers. Okay, sclera is covered by two more layers. One is kind of a fibrous tissue, which is known as Tennant's capsule. And as we discussed in conjunctiva, that conjunctiva also covers the bulbar part. The bulbar conjunctiva covers the sclera. Okay, so in the interior part, in the front part, it is covered by the bulbar conjunctiva. Okay, so keep this in mind. The sclera is not bare. Like cornea is not covered by anything because it has to be transparent. Sclera is covered by two layers. One is known as tenon capsule, and then on the top of that, there is bulbar conjunctiva. Right? Then the two things which you need to remember about sclera, like, in the tissue, like sclera is going from limbus and it is going all behind till the optic nerve area. That is what we read in the anatomy. The thickness of the sclera is different in different parts. The thickness of the sclera is different in different parts. The thinnest area, now this can be asked as question, the thickest and the thinnest area, please mark it. Thinnest area is posterior, just posterior to insertion of recti muscles. Okay, so recti muscles, the extraocular muscles. Yesterday you saw when I showed you the picture of the eyeball, that extraocular muscles, they are getting attached onto the sclera. Okay? So the thinnest part is just posterior to the insertion of these rectus muscles or the extraocular muscles. And what is the importance, clinical importance? So when there is a trauma, when there is a forceful trauma to the eyeball, the sclera can rupture at its thinnest area. So this particular area will be prone to rupture due to blunt trauma. Okay, this will be prone to rupture due to blunt trauma. And which is the thickest area? Thickest area is peripapillary area. Peripapillary means around the optic disc. Around the optic disc. That is the posterior part. That part is thickest. Okay, so this is important for question, which is the thinnest area and what is the clinical relevance? That if there is blunt trauma, then sclera can rupture in that area. And thickest area is around the peripapillary area. Okay. Now, in the scleral diseases, we need to know about inflammation of sclera, okay, which is known as scleritis. Inflammation of sclera, which is known as scleritis. Now, in the inflammation of sclera, it is divided into two types, episcleritis and scleritis. Episcleritis and scleritis. Okay. Now, what is episcleritis? When only superficial sclera is involved. Okay. When it is only superficial sclera which is involved in the inflammation, that is called epi. Epi means surface. Only superficial sclera is involved in inflammation. Okay. Scleritis when deep sclera is involved. Deep sclera is involved, then we call as scleritis. And what can be the reason for this inflammation? This is usually associated with different collagen vascular diseases. Different collagen vascular diseases. What do I mean by collagen vascular diseases? For example, you must have read in your medicine, Wegener's granulomatosis. Wegener's granulomatosis. Polyarthritis nodosa, polyarthritis nodosa, and then very importantly, rheumatoid arthritis. Rheumatoid arthritis. Now, rheumatoid arthritis, please mark it as a star. Right? So whenever there is scleritis or episcleritis, remember rheumatoid arthritis because it is a very common association. And usually the question is also related to rheumatoid arthritis and scleritis. Okay, so don't forget the patients of rheumatoid arthritis are at risk of developing scleritis, either episcleritis or scleritis. Okay? So this is very important association. Besides this, sometimes the cause is idiopathic. We do not know exact association. Okay. It can be due to certain infections, right? And then another disease which can cause scleritis or episcleritis is sarcoid. Sarcoid. So these are the common associations. And as I told you, even if you forget everything else, please do not forget rheumatoid arthritis. Okay. So scleritis, episcleritis, rheumatoid arthritis, they are closely associated. Okay. Now, something more which we should know here. Now, when I speak of episcleritis, like how the episcleritis will present, episcleritis is superficial inflammation. So patient will have mild pain and superficial congestion. Mild, so it is a mild disease. Episcleritis is a mild disease. Just some mild redness and mild pain. So this is how it will look like. Okay. So you see, this is like diffuse. The diffuse redness is there. This is called diffuse episcleritis. And it can also be nodular, like a nodule here. Nodular episcleritis. These are the two type of presentations. Okay. Usually I do not expect these images to be in the exam. Usually scleritis question, episcleritis images are not there. So here I'm not telling you this is for exam. This is for your understanding. So it can be diffuse episcleritis or nodular type. What you need to remember it is a mild disease. So treatment, either it can be self-limited or you can use topical non-steroidal anti-inflammatory drops. Okay? Because it is a mild disease. Fine? Simple. Episcleritis, mild disease, mild treatment. Scleritis. Now, scleritis is a severe inflammation because it is a deep tissue involvement is there. So scleritis, S, severe inflammation, severe pain, SSS. Severity, scleritis means more severity. So there is severe inflammation, severe pain, and even the clinical presentation also, you see this is diffuse type. This is nodular type, but much more severe here as compared to the images which you saw of episcleritis. Again, these images are not expected in the exam. This is for your understanding, how the diffuse scleritis or nodular scleritis will look like. Okay? So it is a severe disease. Patient can have severe pain. Now, the scleritis is further divided into two types. Okay, it is further divided into two types. One is called beta, there is some misprint here. Please write it here. Two types it can be. One is called necrotizing. Necrotizing. And second is called non-necrotizing. Okay. The further two categories they can be there. One is called necrotizing. The second is called non-necrotizing. So it is self-explanatory that when there is scleral necrosis, there is inflammation as well as necrosis. So it can be a very dangerous disease because when there is necrosis, there can be thinning of sclera. There can be thinning of sclera. And one type of necrotizing is, now this can be asked, okay? This can be asked, one type of the necrotizing it, scleromalacia perforans. Okay, so please mark this as a question and important star. This can be asked as an image-based question and a case scenario also. Okay, so concentrate here. Scleromalacia perforans. So scleromalacia means necrosis of sclera with thinning. Okay. Now this is usually seen in the patients of long-standing arthritis. And you can imagine this can be very severe disease. You see how the sclera has become thin. Why it is appearing black in color? Because the underlying uveal tissue, sclera is the outer layer, which is the middle layer, uvea layer. So when the upper layer will become thin, the middle layer shines through that. So that is why you are seeing it blackish, because sclera has become so thin that the uveal layer is shining through it. So this condition is a particularly dangerous condition. It is called scleromalacia perforans. It is associated with long-standing rheumatoid arthritis. So please do not forget these 2 points for your exam. Scleromalacia perforans, long-standing rheumatoid arthritis. What is happening here? The sclera is becoming progressively necrosed along with thinning. Okay. Now, one last thing in the scleritis, please write it down here. There is another condition called posterior scleritis. There is another condition called posterior scleritis. Okay, please write it down. So posterior scleritis means when there is involvement of the sclera, the posterior part of sclera, not the front which you are seeing, at the back. Okay, so eye is, you are able to see only the front part of the eye. There is a lot of eyeball behind also. We saw in the orbit. Okay, so when there is involvement of the sclera, only the posterior part, then it is called posterior scleritis. And the posterior scleritis, because that is the part of the sclera which is in the posterior segment area. Okay, so it involves 2 signs are associated with this, which you need to remember. Okay, one is known as exudative retinal detachment. Please write exudative retinal detachment. So retinal detachment is the detachment of retina. Okay. Now in the condition called posterior scleritis, because that is in the back part of the sclera, it can cause exudative retinal detachment. Okay. We need not go into much detail here, because you need to have focused learning. There is so much material. You cannot remember or do think, but key points where we expect the questions, they should be remembered. So that's why I'm just telling you 2 points about posterior scleritis. One is it can cause exudative retinal detachment. Secondly, the presence of what is called T sign on ultrasound in the cases of posterior scleritis, which is diagnostic of posterior scleritis. Okay, so I know it is, you might be feeling a kind of little incomplete there, but we do not need more about posterior scleritis. Just 2 things you need to remember. If in the question they ask the T sign on ultrasound is seen in which condition, so that is seen in the cases of posterior scleritis. Ultrasound of eye I am talking. So T sign is due to actually the inflammation of the sclera, which can be picked up on the ultrasound. So T sign on ultrasound and exudative retinal detachment, these 2 are associated with posterior scleritis. Is that fine, beta? This is what we need in sclera. Okay. Just to sum it up, what you need to know in sclera, a little bit of anatomy, that it is covered by tenon layer and bulbar conjunctiva, which is the thinnest part, which is the thickest part. The inflammation can be of 2 types, episcleritis, which is mild, scleritis, which is severe and very painful. Okay, the most common association is with rheumatoid arthritis. There can be other diseases also, but most common association is with rheumatoid arthritis. Okay, then you need to remember that the scleritis can be necrotizing type and non-necrotizing type. Necrotizing type is severe because it causes thinning of the sclera with necrosis. A special condition is named as scleromalacia perforans, and it is associated with long-standing rheumatoid arthritis. Okay, and the last, there is another condition in which only posterior part of the sclera is involved. That is called posterior scleritis. In posterior scleritis, two features you have to remember. It can cause exudative retinal detachment, and it will show T sign on ultrasonography. T sign on ultrasonography. Okay, is that fine, beta? Okay, so with this, we have come to the end of the sclera. Also, very few points were needed there. And now the next chapter which I will be starting is the chapter of the lens. We will do the lens first. Okay, so lens should be somewhere. No. Yeah, so it is your page number 90. Optics and refraction we will be doing after doing the lens, because that will make more sense to do that. So we will be next going ahead. You can come to the page number 90. We'll be starting the chapter of lens. Before that, okay, before the optics and refraction. So let's start with that. In another half an hour, we can go for tea break, but we can start with the chapter of lens first, I think, isn't it? Right? So friends, please come to the page number 90 in your workbook. I'm waiting for you. Page number 90 in your workbook, the chapter of lens. The chapter of lens. So in this, we will be talking about some things about the anatomy of the lens, and then a very important topic of cataract. Okay. So all of us are there. All of us are there. Okay, so lens. So come to the figure 9.1 to understand the anatomy of the lens in relation to the anatomy of the eyeball. Okay, so if you recall the basic anatomy which we did, so I told you the lens is suspended in the eyeball. Okay, it is suspended or kind of hanging in the eyeball. It divides the eyeball into posterior segment, the part which is behind the lens, and anterior segment. Okay, so this is how, once again, you can imagine the lens is present inside the eyeball. Okay, this is your lens, right? So this is the anterior part, this is the posterior part, the wall. Now the cavities, we know this part is filled with vitreous gel, this part is filled with aqueous humor. You have this fair idea now how the things are. Okay, the lens is suspended in the eyeball. How it is suspended? There are, like, what we call as this, which I have marked here, and you can write it down. There are fibers which are known as zonular fibers, or they are also called suspensory ligament. Okay, so there are zonular fibers, or they are also called suspensory ligament, which are attached. Where they are attached? They are attached to the ciliary body area. If you remember, so these are attached to ciliary body area. So these fibers are attached to ciliary body area, which keep the lens in its position. Okay, because it's kind of hanging there. So the lens is kept in position by these zonular fibers or suspensory ligament, which are attached to ciliary body area. Okay, so you get an idea how the lens is placed in the eyeball, right? Now, some points about the anatomy of this lens. Now, the lens is called crystalline lens. We call it as crystalline lens because it is made up of crystalline protein. Okay, so the lens, you will notice in the books the term written as crystalline lens. Now, the shape of the lens is biconvex. Okay, so this area which is convex, anterior surface, and then the posterior surface. So we call it as biconvex, that both the surfaces are convex, anterior and posterior. But the thing is, the anterior surface is less curved than the posterior. The anterior surface is less curved than the posterior surface. There is difference of the radius of curvature, right? The anterior surface has more curvature, the radius of curvature is more, and posterior surface, the radius of curvature is 6 millimeter, anterior surface is 10. Now here, do not get confused. More is the radius of curvature, less is the curve. You know, I'm just, because sometimes you can just get confused by this thing, what I'm saying. Now, when we talk about radius of curvature, so this is the circle, imagine any circle. This is the radius of curvature of this circle. And then this is the radius of curvature of this circle. Now, if I take this segment and this segment, which segment is more curved? Now, this segment is more curved or this segment is more curved? Curve. This is more curved because smaller is the radius of curvature. That part will be more curved. You are looking at this, na, beta? Just I'm trying to explain here. This is more curved. This is less curved. But radius of curvature is more here. This is less here. This is just for your understanding so that you don't get confused what I have written here in the notes. Because sometimes the question, it becomes like, just let me go back there. That, ma'am, you have written anterior surface is less curved, and then you are writing the radius of curvature of anterior surface more. This is what it is. The radius will be more, the surface will be less curved. Okay, right? Then something regarding the refractive index. The refractive index of the lens is different between the two parts of the lens. The central part of the lens is called nucleus. This central area is called nucleus, and the outer area is called cortex. So the nucleus has more refractive index than the cortex. And refractive power of the lens is between plus 14 to 16 diopter. Okay, so why we are mentioning this? See, for two structures, for cornea and lens, these are the two structures which are the refractive surfaces of the eye. And they are contributing to the refractive power of the eye, as I told you in cornea also. So cornea is the major contributor and second number is lens. So these two structures we'll be discussing in optic refraction, how they are helping to focus the light on the retina. So that is why these things are important to know. So lens, the central part of the lens has more refractive index. So more refractive index means it has more refractive, it can bend the light more. Okay. Now, in the part of the lens can be divided into, as I told you, the centralmost part is the nucleus, like I have marked here. This is your nucleus. The outer part is cortex. So this part will be the cortex. And the whole of the lens is covered by a very thin capsule, like this. This is your capsule. Okay, so this is a rough diagram to make you understand the different parts of the lens. So the centralmost part is your nucleus. Then outside the nucleus, the part is called cortex. And this whole lens is covered by a lens capsule. Okay, friends? Right? And what is the material the lens is made up of? As I told you in the beginning only, the lens is majorly made up of protein material, and the lens proteins, they are called crystallins. So this sometimes can be asked, that which is the protein in the lens, or lens is made up of which protein. So the proteins of the lens, they are called crystalline. There are three types of the crystalline: alpha, beta, gamma. And alpha are the maximum. Alpha crystalline are the maximum. So this can be asked there in the exam. The protein, lens protein is crystalline protein. Three types: alpha, beta, gamma. And alpha is the maximum. Alpha crystalline is the maximum. Okay. Now something more about the structure of the lens. Please come to the figure 9.2. This is to, again, for your understanding how the lens structure and how the lens develops during the different age groups. Okay. Now the lens is one structure which keeps on growing throughout our age. Okay. So when there is embryonic, during the embryonic time, you remember I told the lens develops from surface ectoderm. So the lens starts growing and it keeps on growing till, like, old age. Okay. So this is one part of the body which keeps on growing, just like, your nails, unless you cut them, they will keep growing. So similarly, the lens also keeps growing. So what is happening here, that lens, now have a look here, beta. Now when the lens begins in the body, like, the lens is like this, supposedly during when it starts developing. The lens has new lens fibers. So these lens fibers, they keep on adding around the part of the lens. So new fibers, they keep on adding like this. More. Okay. So supposedly at birth, it was like this. Then in 2 years, it will become like this. In 4 years, it will become like this, and so on. New fibers, they keep on adding to the lens. And the old fibers, they become compressed. It is not that it is going to expand in the size, otherwise the eyeball will burst. The fibers, they become more condensed. Okay, but it keeps on growing. So this is to give you an idea that how the lens keeps on growing. So since the lens keeps on growing, it shows it different parts at the different parts of the development. So we call the central part of the lens, which is the nucleus area, will show different areas depending upon when that part developed. Okay, so you can imagine, just to give you an idea, the old trees, they have got big stem, and you tell that if you cut the stem, you can tell the age of the tree, because the central area will be the oldest, then the outer ring, and then the outer ring. So it's just almost like that. Okay. The centralmost part of the nucleus was developed during the embryonic period. We call it as embryonic nucleus. Then the outer part which developed during the fetal time, that is called the fetal nucleus. Then infantile, that is during the infant period from birth to puberty. Then adult time. Okay, so these are the different areas which grew during different age group. Now it doesn't mean that it is showing these kind of lines actually. This is just that we know that this happened, that it starts with a small nucleus, then old new fibers, they keep coming, and this whole area becomes, shows us different zones at how the different period of time it was growing. Okay, but ultimately this whole central area is your nucleus of the lens. This whole central area is your nucleus of the lens. Okay, so even if you don't remember the different names, it is fine. Just you should know that this nucleus was growing throughout, and the older fibers are in the center, the newer fibers are on the outer side. Okay, so outside the nucleus is your cortex area, which has the youngest fibers, because ultimately those fibers will also come in the center and new fibers will be on the outer side. Okay, and the whole thing is covered by a thin capsule. This whole thing is covered by a thin capsule. Now, this is the anterior part, this is the posterior part. So the anterior part is called anterior capsule. The posterior part is called posterior capsule. Anterior part is called anterior capsule. Posterior part is called posterior capsule. Okay? Now, one more thing to know is, as you see, the anterior capsule is lined by epithelial cells. The anterior capsule is lined by these epithelial cells. And these epithelial cells are the ones which produce the lens fibers. Okay, so let me summarize it for you so that it is more clear. Let me summarize it to you that it is more clear. What you need to make a concept in your mind: the lens starts developing from the embryonic life and it keeps on growing throughout the age. Okay, the old lens fibers, they get condensed in the center in the form of the nucleus. So you just need to understand this. There is nothing to write, so please don't bother writing. The old fibers, they get condensed in the center at different periods of life, during embryonic period, fetal period, infantile period, adult period. Okay, so they get condensed in the center and they form the nucleus. The young fibers are on the outer side, they form the cortex of the lens. Whole of the lens is covered by a capsule. Okay, now the capsule on the anterior part of the lens is called anterior capsule. The capsule on the posterior part of the lens is called posterior capsule. Okay, the anterior capsule is lined by epithelial cells. Anterior capsule is lined by epithelial cells, and it is actually the epithelial cells which produce the new lens fibers. The epithelial cells which produce the new lens fibers. Okay, and these lens fibers, they are majorly made up of protein. Which protein? Crystalline protein. Crystalline protein. Okay, is that all right? Now let's see what we have mentioned here in our notes. The same thing which I told you. So the lens capsule, the anterior lens capsule has lens epithelium. Okay, which the nature is like, cuboidal cells, and they become columnar as you go to the edges. Okay. I think this is, you can just cut this equatorial, just stop it. And so lens capsule, I mean, this is some kind of misprint here. So you have seen I have cut this. You can just cut this equatorial and lens capsule, which has written there. Okay. So lens epithelium produces the lens fibers. Lens epithelium produces the lens fibers. Then the posterior lens capsule has no epithelium. The posterior capsule has no epithelium. The lens capsule is considered to be the thickest basement membrane in the body, because this capsule is also produced by the lens epithelium. The capsule is also produced by the lens epithelium, and it is considered to be thickest basement membrane in the body. Now, this lens capsule is not of uniform thickness. The lens capsule is not of uniform thickness. So see this figure here. Now, when we talk about the lens, just like, Earth has an equator, so you can imagine that there is an equator cutting the lens into upper half, anterior half, and posterior half. So the lens capsule is thickest in the pre-equatorial area, this area. And it is thinnest at the posterior pole. Okay. The lens capsule is not of uniform thickness. If you imagine an equator of the lens, just like equator of the Earth, which is converting it into interior half and posterior half, the area which is just around the equator, in this part, the lens capsule is thickest. And in the posterior pole area, the lens capsule is thinnest. Now, why I am telling you this? Because this can be asked as a question also. Okay. So why I am telling you this? Because they can ask you which is the thinnest part of the lens capsule. So that is the posterior pole, the posterior area. And which is the thickest part? The pre-equatorial area. Right? And as I have written here, the lens grows throughout the life, as I told you. Okay. So a lot of information there. So to summarize, to make it easy for you to revise so that the understanding is complete here, what you need to know, just listen to me. When you listen to me and read back, you will see that the same thing is written there. So lens, how the lens is suspended in the eyeball with the help of suspensory ligament or zonules, which are attached to the ciliary body. The lens is kind of hanging within the eyeball. Okay. Now this lens has three parts. The centralmost part is the nucleus of the lens. Outside the nucleus, there is cortex of the lens, and this whole lens is covered by a capsule. Now the capsule can be divided into the anterior capsule and posterior capsule. The anterior capsule has lens epithelium, and it is the lens epithelium which produces the lens fibers as well as the capsule of the lens. The lens fibers, they keep on growing throughout the age. And the old fibers, they get condensed in the center. The new fibers, they are laid on the outer side. These lens fibers, they are majorly made up of crystalline protein. Okay. The lens capsule is not of uniform thickness. It is thickest at the pre-equatorial area of the lens and thinnest at the posterior pole of the lens. Okay. So these were the points which I wanted to highlight about the anatomy and structure of lens. Okay, beta? right? And same points are written here. So when you revise, you'll be able to get an idea what I am telling there. Now, few more things about the lens, and then we take a break. Now, lens, just like your cornea, is avascular. You know, the refractive surfaces, they have to be avascular because only then they can be transparent. So the lens also has to be transparent, just like cornea, because the light has to pass from the cornea to the lens. So just like cornea, lens is also avascular. It has no blood vessels. Then how it is getting its nutrition? It is getting its nutrition from the aqueous humor and from the vitreous humor. Because in front of the lens, there is aqueous humor. Behind the lens, there is vitreous gel. So it is getting nutrition from both these fluids. Okay? The major metabolism of the lens is anaerobic. Now, this is in contrast to the cornea. If you remember, the corneal metabolism is majorly aerobic. But the major metabolism of the lens is anaerobic. Okay? Then one more thing which you need to know is the lens is a structure in the body which is very susceptible to oxidative damage. Now you understand oxidative damage, like, you know, in our body, you must have read in biochemistry or physiology, in our body, when the different kind of chemical reactions are happening, there is lot of free radicals which are released, free radicals, which cause oxidative damage to the tissue. So, like, you know, the aging, like why we age, because in our body, these free radicals, they increase with the age, they are causing oxidative damage to the different structures. So lens is one structure which is very susceptible to the oxidative damage. So nature has given certain antioxidants within the lens to control this oxidative damage. Okay, nature has given certain antioxidants in the lens itself which help preventing the oxidative damage so that the lens remains clear. What will happen if there is oxidative damage? The lens will not remain clear. There will be the kind of the changes, chemical changes, which will make lens opaque. And as I told you, just like cornea, the lens has to remain transparent. Only then we can see clearly. So what are the antioxidants which help the lens to prevent the oxidative damage? This is the list. This has been put here for you to learn because in the past, the questions they had come. So this has come as a question that what antioxidants in the lens can prevent the oxidative damage. So please remember the list. They are glutathione, superoxide dismutase, catalase, vitamin C, vitamin E. Okay. So these are the antioxidants which prevent the damage to the lens. Fine. So here we take a break, and so that then once we come back, then we can start the topic of cataract, which is the important topic in the lens chapter. So you know what the lens is, what are the different parts of the lens, what is the protein of the lens. And as I told you, what you have to remember, once more I'm stressing that lens is a clear structure. A clear lens is responsible for the good vision because the light passes through the lens. If there is any opacity in the lens, the vision will reduce. And actually, this opacity in the lens is only called as cataract. So once we come back from our tea break, we are going to discuss what happens when there is cataract, different type of cataracts and management of cataracts. Okay, friends. So let's break here for a tea break of 20 minutes. Tea, coffee, juice, whatever you like. So break for 20 minutes, my dear friends, and then we come back and start with the topic of cataract. Okay, fine. Thank you. See you then. Welcome back, friends. I'm showing here the page number 72 once more. I'm showing here the page number 72 once more. Abhijit, if you're here at the moment, you had some doubt here. Page number 72 in the workbook. So here there is a misprinting. As I told you, I'm going to repeat it also. This non-necrotizing is not a heading. The non-necrotizing is not a heading here. So scleritis can be divided into two types, necrotizing and non-necrotizing. Okay, so please mark it like this. The non-necrotizing should not be the heading. The scleritis can be of two types, necrotizing and non-necrotizing. And this scleromalacia perforans is example of necrotizing scleritis. Okay, because it is appearing as if it is a non-necrotizing scleritis. No. Okay, so please make it clear so that you don't have any confusion here. Scleritis is of two types, necrotizing and non-necrotizing. And this figure 7.4, which is of scleromalacia perforans. So scleromalacia perforans is an example of necrotizing scleritis. Fine, is it clear now? Right? Okay. So now we go back to from where we left. Coming to page number 92, beta. Let's all of us go back to page number 92 in your workbook. And we are going to start with the topic of congenital cataract. Congenital cataract. Okay, so just resuming from where we left. So as I told you, a normal lens should be clear. Now, when there is any opacity of the lens, that is called cataract. Okay, so what will be the cataract when the lens is no longer clear and there is opacity in the lens? That is known as cataract. Any opacity of the lens will be called as cataract. Okay. Now, there can be different types of cataract. So two major things you can mention here, that cataract can be congenital or acquired. So any opacity of the lens is cataract. Cataract can be congenital or acquired. Okay. And now we are going to discuss congenital cataract. Now we are going to discuss congenital cataract. So what could be the congenital causes of congenital cataract? Now, causes of congenital cataract, it can be idiopathic. So that is the most, you can say, simple thing to know, that we do not know exactly what is the cause. Okay? So it can be idiopathic. It can be hereditary. Now here it is important to remember, if it is hereditary, it is then autosomal dominant, and the gene which has been associated with the cataract is Cry gene. Cry is for crystalline, the crystalline lens, the protein in the lens. Okay? So this is important point to remember, that which gene is implicated for hereditary congenital cataract, that is cry gene. And how will I remember? Children, they cry. So congenital cataract, cry gene. So you can remember like this. The children, the babies, they cry. So congenital cataract is associated with cry gene. Another way to remember is cry stands for crystalline protein, which is the protein in the lens. So it is actually cry gene is implicated for congenital cataract. Then the other important cause of congenital cataract is if during the pregnancy, mother has certain problems. For example, what could be the maternal factors? Torch infections. Torch infections, you all know what all comes in the torch infections. That is, if the mother had toxoplasma infection or rubella or cytomegalovirus, CMV, or herpes during the pregnancy, then the child may be born with congenital cataract. Okay? So if the mother has these torch infections, that is toxoplasma, rubella, CMV, or herpes infection during pregnancy, the child may be born with congenital cataract. Then if mother suffered from malnutrition during the pregnancy, especially if there is vitamin D deficiency, or hypocalcemia, that is calcium deficiency, then the child can develop cataract, congenital cataract. The child may be born with congenital cataract. Okay, so malnutrition in the mother, vitamin D deficiency, or hypocalcemia. Then intake of certain drugs during the pregnancy, especially steroids or thalidomide. If the mother took these drugs during pregnancy, then again, risk of the baby developing congenital cataract is there. Okay, so these are the maternal factors which can cause congenital cataract. Then malnutrition in the baby itself. Okay, so if the baby is born with vitamin D deficiency or hypocalcemia, then again the cataract can develop. Any trauma during the birth, right? Any trauma during the delivery or the birth, then certain chromosomal abnormalities, if the baby has like Down syndrome, or certain associations with syndromes, for example, Marfan syndrome or Lau syndrome, these babies, they have congenital cataract. Okay, so this is the list here that what can be responsible for congenital cataract. Now here, just one thing I want to let you know, that when we talk about congenital cataract, it also includes the developmental age. It doesn't mean that it has to be just at the birth. During the developmental age, we also call it as developmental cataract. Okay, so it can be within few months of the birth that the cataract progresses, not exactly at the birth. Okay? So the points to be remembered here is the cry gene, and then maternal factors, and then association with certain syndromes. So all these, they are the different causes of congenital cataract. Okay? Now, when we speak about cataract, there are different type of cataracts depending upon what kind of opacity or what is the appearance of the cataract. Okay, so now you are going to learn about different types of cataract depending upon which part of the lens is opacified and what is the appearance of the cataract, morphological appearance of the cataract. Okay, so depending upon the morphological types of the congenital cataract, there are different types of cataract. One type of the cataract is called punctate cataract, or commonly known as blue dot cataract. It is the most common congenital cataract. Okay. So how does it look like? This is for your understanding. This is how the blue dot cataract looks like. Blue dot cataract. You see these multiple opacities, like bluish dot like opacities. So by the appearance of the cataract, the name of the cataract is given. So this is blue dot cataract, which is also known as punctate cataract. It is the most common congenital cataract. But the thing to remember is, now you see here the opacities are there, but they are scattered and they are not causing much opacification of the lens. So this actually does not causes much vision problem. It is considered to be visually insignificant. Okay, these type of opacities, they do not cause much vision problem. This type of cataract is considered to be visually insignificant. Okay, so you can write here, punctate cataract is visually insignificant. Visually insignificant. The punctate cataract or blue dot cataract. And it is the most common congenital cataract. Okay. The second type is what is known as zonular or lamellar cataract. Now this is commonest visually significant. Okay. So blue dot is commonest but visually insignificant. The zonular or lamellar is commonest visually significant cataract. Okay, so this is how the zonular cataract looks like. So as the name is suggesting, zonular means one particular zone or lamellae has this opacity. You see, this opacity is in one zone or lamella of the lens. So that is why it is called zonular or lamellar cataract. And as you can see, this is a dense opacity. So this causes vision problem. So it is most common visually significant cataract. And then another thing you have to remember is a feature of what is called riders. So, you know, there is a central opacity and these rider-like opacities. So they are also seen in zonular cataract. So this can be asked as a question, that riders are feature of which type of cataract? So riders are features of zonular or lamellar cataract. Okay, so this can be one-liner question, that the riders are feature of which type of cataract? It is the feature of zonular cataract. Then the question can be, as I told you, the blue dot cataract, commonest but visually insignificant. Zonular cataract, visually significant. Okay. Now here again, there is little bit of printing is not very clear. On the top of these 2 points, beta, hypocalcemia and vitamin D deficiency, please write down zonular cataract. Please write down zonular cataract here. So these two are the causes of zonular cataract. The hypocalcemia and vitamin D deficiency are the common cause of zonular cataract. Okay, so am I clear here? So put a heading of zonular cataract before these 2 points and write it like this. So hypocalcemia and vitamin D deficiency, they are causes of zonular cataract. Is that all right, beta? Okay. Then coming back to the list of the types of cataract, another type of the cataract is called nuclear cataract, which is seen in congenital rubella syndrome. So again, this can be your one-liner question, that which type of the cataract is seen in congenital rubella syndrome. It is nuclear type. Then depending upon which other, like, you can remember types. One type is called coronary, in which there are cortical club-like opacities. One type is called sutural. One type is called polar. But these three are more important to know: punctate, zonular, nuclear. Okay, these three are more important to know. Punctate, blue dot cataract, most common, visually insignificant. Zonular or lamellar, as I told you here, most common, visually significant, has riders. The causes are hypocalcemia and vitamin D deficiency. Okay. And the third, which you remember, is the type of cataract seen in congenital rubella. So this is the pearly nuclear cataract. This picture is just for your understanding how the cataract looks like. You see this cataract here, like a pearl. So pearly nuclear cataract is the type of cataract seen in congenital glaucoma. So this again can be the one-liner question. So in the chapter of cataract, lot of one-liner questions, they can be there, that which type of cataract is seen in which condition. So keep marking what I tell you are the important ones. Okay. So here is about your congenital cataracts. Okay. So three things to remember: blue dot cataract, zonular or lamellar cataract, pearly nuclear cataract, and congenital rubella. Fine, beta? So this is just a picture of sutural cataract, how it looks like. But again, this is more for your understanding. Not that you should, like, exam. I don't really expect this, but it is just like, to tell you how the different parts of the lens can have opacity, and hence the name of the cataract. Okay. Okay, so those were the morphological types and causes of the congenital cataract. Now we come to the acquired cataract. So in acquired cataract, the most common is age related. Okay, which is known as senile cataract. Okay. So please write here, the most common acquired cataract is your senile cataract, that is age related. Okay, senile cataract, that is age related. This is one and the same thing. So most common acquired cataract is senile cataract or age related. Now, what happens in the senile cataract? That why the cataract develops. Okay, so now this is for your understanding, and that will help you to understand the types of cataract which we see with acquired cataract. Now, with the age, what are the changes which can happen in the lens which can cause cataract? The two kind of changes they can happen. Okay, one is that the normal crystalline proteins, I told you that lens protein is the crystalline protein. The normal crystalline protein is a soluble type of protein. Now with age, what happens? It gets converted into insoluble crystalloids. Now when the nature of the protein changes, the refractive index of the lens changes. When the nature of the protein changes, the refractive index changes, it becomes increased. Okay, due to which the lens becomes what we call as myopic. It causes myopic refractive error. We call it as index myopia. I will tell you more about myopia and refractive error, but whenever there is increased refractive index, that refraction means the the converging power of an optical surface is increasing when there is more refractive index. Okay, so that will lead to myopic refractive error. And these type of the changes, they occur in nuclear type of the cataract. In old age, the senile cataract, we call it as nuclear sclerosis cataract. Nuclear sclerosis cataract. Okay, so please see again what is happening. One type of change which can occur, that the normal soluble crystalline protein in the lens changes into insoluble crystalloids. That leads to increased refractive index of the lens. This type of change is seen in nuclear sclerosis type of cataract, and it causes a myopic refractive error in the eye. We call it as index myopia. Index myopia. Okay. The second type can happen that the lens fibers, they become hydrated. Okay. There is decrease in the protein of the lens and increase in the sodium in the lens, which leads to hydration of the lens. Now, when anything becomes hydrated, it will lose its transparency. Like, in the cornea, I told you, cornea becomes hydrated, transparency is lost. Similarly, if lens becomes hydrated, the transparency is lost. So when the lens becomes hydrated, there is loss of transparency, and this occurs in cortical type of the cataract. Okay, so these two things are the changes, either of which or even a combination of which can happen, which leads to development of senile cataract or age-related cataract. Okay, now why we are interested to know this? Because this can also come as a question, that what are the changes which are occurring. So this has come as a question in the past exam, that what is the change in the lens happening? The soluble crystalline protein, mark it as an important point, getting converted into insoluble crystalloids. And this leads to nuclear sclerosis type of cataract. Okay. And similarly, the second thing which can happen is the hydration of the lens, which leads to loss of transparency, and that leads to cortical type of cataract. Okay, so these are the causes. Now the morphological types of the senile cataract. In the morphological type of the senile cataract, so as already we have spoken about, it can be involving the nuclear area, which is known as nuclear senile cataract, or also called nuclear sclerosis. Okay, so one type of the senile cataract will be, which is involving the nucleus of the lens, the nuclear part, and that is known as nuclear sclerosis. The second type of the cataract will be which involves the cortex of the lens. Sorry, which involves the cortex of the lens. Now, cortex of the lens, the changes, they can occur in two forms. Okay, one is, you can put it as A. One is called cuneiform cataract, and second is called cupilliform cataract. Okay, one is called cuneiform cataract and second is called cupilliform cataract. In cuneiform cataract, the peripheral area of the lens has wedge-shaped opacities. In cuneiform type, the peripheral area of the lens has wedge-shaped opacities. Whereas in cupulliform, the changes they occur in subcapsular area. I'll just show you the picture so that you will understand also. So first of all, just read it out first. In cupulliform, the opacity or the cataract is in posterior subcapsular area. Okay. Then in the third category is called as subcapsular cataract. Here the opacity can be under the anterior capsule or under the posterior capsule. So as I told you, we name the cataract depending upon the morphology of the cataract, that which area of the lens is showing opacity. So in acquired cataract or in senile cataract, you can think it of three types. One is your nuclear type, which is involving the nucleus. One is of cortical type. Cortical type can further be of two types, cuneiform or cupulliform. And then subcapsular, which is anterior or posterior. Okay, so let me show you the figure so that you understand it well. So these figures are to explain to you how the cataract looks like. Okay, now see this figure here and see this lens here. You see this lens here is appearing opacified. Okay, and the nuclear area, this is the outer part. The outer part is not that affected, but it is the nuclear area which is affected. So it is nuclear sclerosis type of cataract. This is not symptoms. Cut this off, beta. Symptom, the word symptom which is written, please cut it off, friends. So nuclear sclerosis will be when it is involving the nucleus of the lens. Okay. Then let me take you to the figure 9.9, the cortical cataract. See these opacities, they are in the cortex part of the lens. And this typical one is cuneiform, wedge-like opacities, cuneiform. Okay, right? And let me take you to another figure. We are going to come back here again, figure 9.10. So here you see, this is the anterior part of the lens. This is the posterior part of the lens. This whole area is clear. And where is the opacity? In the posterior part, just under the capsule. In the posterior part, just under the capsule. So it is posterior subcapsular cataract. Posterior subcapsular cataract. Similarly, in case if the opacity is here, okay, similarly, in case if the opacity is here, then what will I call it as? Then the cataract will be named as, it will be named as anterior subcapsular cataract. Anterior subcapsular cataract. Okay, so you got an idea that how we name or why this kind of name is given to different type of cataract depending upon which area is involved. If nucleus is involved, it is nuclear cataract. In a senile age group, we call it as nuclear sclerosis cataract. If cortex is involved, it is cortical cataract. If subcapsular area is involved, it is subcapsular cataract, which can be posterior subcapsular or anterior subcapsular. Okay. Now coming to the specific features of each type of cataract. Coming to specific features of each type of cataract. Come back to page number. When I come back to page number 95, we are going to learn the specific features of each type of cataract. So first of all, nuclear sclerosis. Nuclear sclerosis. Okay. So in the nuclear sclerosis, as I told you, the changes, they are in the nuclear area of the cataract and the lens. Nuclear area of the lens. Now, nuclear sclerosis cataract, already I told you the cause, what is happening. The soluble crystallines, they are getting converted into insoluble crystalloids. Now, this makes the lens appearing yellowish in color. Okay, the lens becomes yellowish in color. And as the cataract progresses, it can even become brown in color. Then it is called brown cataract or cataract brunescence. Okay. If it progresses further, the lens can appear even black in color. Black cataract. Then it is called cataracta nigra, black in color. Okay. So in nuclear sclerosis, the normal lens should be absolutely clear. The nucleus should be absolutely clear. But here it starts appearing initially yellow, then it can become brown, and then it can become black. So this is how you will recognize the cataract on slit lamp examination. All these pictures are better slit lamp pictures. You have to examine the patient on slit lamp and then you can identify which type of cataract it is. So in nuclear sclerosis, it can be a yellow colored lens, a brown colored lens, or even when it is very, very advanced, a black cataract. Now in the nuclear sclerosis, another thing which you have to know and remember, nuclear sclerosis leads to second sight of old age. Second sight of old age. So first of all, mark it as an important question and the point. And now I'll explain you what do I mean by this. Okay. The patient, if the patient has nuclear sclerosis cataract, it is said that patient is getting a second sight in the old age. Now listen to me carefully and then we will write the important point. What do we mean by this? Now I'm going to tell you in the chapter of refraction. So we discussed about the distance vision and the near vision. And we discussed about that for near vision, we use the accommodation. Okay. So for near vision, we use the accommodation. Now with age, what happens? You must have seen, like, your parents or your grandparents, they always use glasses for near vision, for reading. When they are reading the newspaper or they are reading a book, they have to use glasses. We have to use glasses because after certain age, usually after 40 to 45 years of age, our near vision becomes poor. So we have to use the glasses. But if a person develops nuclear sclerosis type of cataract, and I told you, nuclear sclerosis type of cataract causes myopia, index myopia. Okay. Now what happens now? These patients, because of the myopic refractive error, they now do not need the glasses for reading. Because of the changes in their lens, they no longer need glasses for reading. So that is known as if they have gained a second sight of old age. A 20-year-old person does not need glasses for reading. But a 50-year-old person needs glasses for reading. That is an age-related change. But if this 50-year-old person in another 5 years develops nuclear sclerosis cataract, then because of the myopia associated with that, now that person does not need reading glasses. And it appears to the person that as if he has gained the second sight. So that is what we mean. So it's a long explanation, but thing to remember is very simple, one line. The question can be, which type of cataract is associated with second sight of old age? That is nuclear sclerosis. Okay, so my explanation is basically more you to understand why it is happening. The question will be very simple. Which type of cataract is associated with second sight of old age? That is nuclear sclerosis. So if your reference, you want to write how to remember this point. So you can write here that person with nuclear sclerosis, person with nuclear sclerosis does not need reading glasses anymore. So that is known as second sight of old age. So this will give you, this will help you remembering this point. Okay, this will help you remembering this point, that now the person who is having this type of cataract does not need reading glasses. So it appears as if patient has gained a second sight. Okay, but it doesn't mean that this patient does not need treatment, because his distance vision will be affected. You know, lens has become opaque, so distance vision will be affected. Just an additional point. Okay, right? So this was the point to be remembered about nuclear sclerosis cataract. Nuclear sclerosis cataract. Fine. Okay, beta. Now, what are the features of cortical cataract? What are the features of cortical cataract? Now, cuneiform type. Cuneiform type. Okay. So cuneiform type, which I showed you here in this, in which there are these peripheral opacities. So cuneiform type of cortical cataract in which this peripheral opacity is there. Okay. Now this type of cataract causes few specific features which are mentioned here. First of all, let's read them. The cuneiform cuticle cataract will cause colored halos. It will cause monoocular diplopia, and it will cause glare or diminution of vision in dim light. Okay, so let's understand this one by one. What is colored halo? What is colored halo, beta? Okay, so this is important to know. Colored halo mean, like, you know, you look at a bulb of white light, and these people, they will see a rainbow like colors around that bulb because of the scattering of the light, diffraction. You know, the prism, if the white light passes and you see the different light, the diffraction from the prism. Okay, so colored halos, they appear in certain eye conditions, that when the person looks at the light source, the light gets scattered and rainbow like shadow appears. There are three differential diagnosis of colored halos. Please write them here only, these points. Make a heading here, colored halos. Colored halos. The cause can be one which I just told you, cortical cataract. Cortical cataract. The second cause is acute angle closure glaucoma. Acute angle closure glaucoma. And the third cause is mucopurulent conjunctivitis. Mucopurulent conjunctivitis. Okay, so these three are the causes of colored halos. If the patient has cortical cataract or acute angle closure glaucoma, in acute angle closure glaucoma, the eye pressure becomes high and the cornea becomes hazy. Okay, It occurs due to hazy cornea in this condition. Hazy cornea. And mucopurulent conjunctivitis, because there will be mucopurulent discharge covering the eye, the cornea. So that also leads to scattering of the light. So these are the three differential diagnoses of colored halos. So patient will tell you that I see around I see the rainbow lights around that. Okay. So how we will differentiate that why the patient is having colored halo? Now conjunctivitis will be a clear diagnosis that the patient is having red eye, and you can say, yes, your colored halos are because of the conjunctivitis. Now, how to differentiate colored halos of cataract from glaucoma? This is important, that whether the patient is giving history of colored halos, whether it is due to glaucoma or due to cataract, because management is different. So this is done with the help of a test which is called FinCam test. FinCam test. Okay. So please write it down here. FinCam test is used to differentiate colored halos of glaucoma from cataract. Colored halos of glaucoma from cataract. Okay, please write it down. The FinCam test, because this can be your question, beta, mark it as a question also. FinCam test is used to differentiate colored halos of glaucoma from cataract. Okay. What is done in this FinCam test? You give a stenopic slit to the patient. Okay. There is a slit like just this is like a round occluder, and then there is a slit in between. You ask the patient to look through this slit. And when the patient is looking through the slit and on the light, if the colored halos, they disappear, that is, the halos are due to cataract. So if the halos disappear by looking through the slit, then it is due to cataract. If they persist, then it is due to glaucoma. Okay. So remember these 2 points. FinCam test is used to differentiate colored halos of glaucoma from cataract. What we do in this, we ask the patient to look through a stenopic slit. If the colored halos, they disappear, then they were due to cataract. If they persist, then they are due to glaucoma. So that can help us in differentiating these 2 conditions. Okay, fine. So this can be, or the question can be based upon the causes of the colored halos and on the FinCam test. The question can be based upon causes of colored halos and FinCam test. Then the patient of cortical cataract can have monoocular diplopia. Diplopia means double vision, that even when one eye is covered, the patient sees double vision. And then the patient can also have glare or scattering of light in dim light, because opacities are there. So when there are no opacities, the light will pass straight. But when there are opacities, the light will get scattered. So you get my point? So these were the points about the cortical cataract, specific features of cortical cataract. Colored halos, wedge-like opacities, diplopia, glare, and how to differentiate colored halos of cataract from glaucoma. That was it, beta. Okay, right? Then specific features of posterior subcapsular cataract. Okay, so here you can give a heading here, posterior subcapsular cataract. Posterior subcapsular cataract. Please make a heading here. Posterior subcapsular cataract. Please give a heading here. So already I showed you how the posterior subcapsular cataract looks like. So this can be asked as an image-based question, beta. So this can be asked as image question. They will show you the image of posterior subcapsular cataract and you will have to identify the type of cataract. So how will you identify? So I'm telling you once more here. Please look at this picture. So this is a slit lamp picture. How to identify posterior subcapsular cataract? You see, this is the anterior part of the lens. This is the posterior part of the lens. The whole of rest of the lens is clear. This is the clear part. And where is the opacity? Just in the posterior part under the capsule. So if you see opacity like this, please make diagnosis of posterior subcapsular cataract. Okay, right? So posterior subcapsular cataract image-based question can come that look at the slit lamp image and identify the cataract. So are you able to identify now? If you see opacity in the posterior part here, rest of the lens is normal. It is posterior subcapsular cataract. Right? Now in the posterior subcapsular cataract, there are two important things to know. It becomes visually significant even in early stages. Why? Because it is right in the center. The opacity is right in the center. So it becomes visually significant even in early stages. And second is the patient will have glare in bright light. For example, during the night time or during the bright sunlight, or when the patient is driving during the night, the patient will come with the symptoms of glare in the bright light because light gets scattered. Okay. So in the case history, this can come as a case question also. This can come as a case question also, that there is a patient who is feeling glare in the bright light and decreased vision. And this is the slit lamp picture of the patient. What is the type of the cataract? So what will be the type of the cataract? Posterior subcapsular cataract. Posterior subcapsular cataract. Okay. The last thing to remember about posterior subcapsular cataract is, it is, write down here, it is also called nodal cataract. It is also called nodal cataract. That is another important point. Okay. So 3 points about the posterior subcapsular cataract. Please make the heading. The heading is missing here. Make the heading of posterior subcapsular cataract along with figure 9.10. The question can come as image-based question. I have told you how to identify posterior subcapsular cataract based upon the image. Then it is also called nodal cataract. Then it becomes visually significant even in early stages because it is right in the center of the lens. And it causes glare or scattering of light in the bright light. So the patient will have difficulty in the bright light or during the night time due to traffic lights. Okay, so this can be a feature in the case scenario. A person who is having decreased vision with glare and difficulty in the night traffic. This is the image of the cataract. So you can easily identify the diagnosis, posterior subcapsular cataract, or the name nodal cataract is also given to it. Okay, beta. So this is important point for your exam. Important point for your exam. Okay. Then coming back ahead, there is another type of the cataract, which is shown in figure 9.11. It is known as posterior polar cataract. It is known as posterior polar cataract. Now here, if you look at the appearance of the cataract, this has like, appearance like onion ring. Okay. So this has appearance like onion ring. So this is how you will identify posterior subcapsular cataract. Posterior polar cataract. So posterior polar cataract has onion ring-like appearance. So this is again a question. Posterior polar cataract has onion ring-like appearance. It is written also below. So if you go here to the next page, posterior polar cataract has onion ring or onion peel appearance. Okay, this is feature of posterior polar cataract, right? Then this cataract is adherent to posterior pole of the lens, posterior capsule. This cataract is adherent to posterior capsule, so it has increased risk of rupture of the posterior capsule during surgery. So at the moment, just mark it as an important point. When I talk about cataract surgery, I will tell you the complication. Okay. The point to be remembered here is that posterior polar cataract is adherent to the posterior capsule of the lens. So during the surgery, there is increased risk of posterior capsule rupture. So this, then we have to we have to be careful during the surgery when we are operating a case of posterior polar cataract. Right? So two things to be remembered about posterior polar cataract. One is onion peel appearance, and the second is increased risk of posterior capsule rupture during the surgery. Okay. So what we have done different type of the senile cataract, and we have done the features of different type of senile cataract, which can be asked as question in your exam. Point to be remembered about nuclear sclerosis cataract, cortical cataract, posterior subcapsular cataract, and posterior polar cataract. Okay. Now coming to the next thing, the stages of maturity of cataract. The stages of maturity of the cataract. Any type of the cataract, it goes into different stages. The initial stage, the later stages. So they are known as stages of the maturity of the cataract. So the first stage is called stage of lamellar separation. Lamellar separation means these are the lens fibers. The lens fibers, they kind of not, in the normal orientation, they tend to separate due to the hydration. So this is the first stage of the cataract development, which is called stage of lamellar separation. Now this stage is reversible. That if the reason for the cataract is reversed, because there can be the other reasons for the cataracts also besides the age, you cannot reverse the age, but if the other causes which are causing cataract are reversed, then the cataract may stop there itself. Okay. So this is the stage of lamellar separation. Then the second stage is called incipient stage or early senile cataract. So when there is hydration, at this stage, it is colored halos are seen, and diplopia occurs. Okay. Then if the opacification becomes more, then there is stage of immature senile cataract. Immature senile cataract. During this stage, the patient now has decreased vision, more decreased vision. But it is incomplete opacification. You can still see the iris shadow on the lens. Okay. It is incomplete opacification and you can still see iris shadow on the lens. Then the next stage is the stage of mature cataract or total cataract, or also called as white cataract. Here the whole lens has become opacified. So you cannot see the iris shadow also. Okay. So in immature senile cataract, the lens is, you can write, the lens is partially opacified. Partially opacified, and you can see the iris shadow on the lens. But in total cataract, the lens is completely opacified. It becomes totally white and you cannot see the iris shadow. If it becomes further, you do not treat and it keeps on becoming more and more mature, we call it as stage of hypermaturity. We call it as stage of hypermaturity. Now, when the hypermaturity occurs, the two kind of changes they can happen in the lens. Okay. So depending upon how the cataract is progressing, in the first stage, it is just the lamellar separation. Then early stage or incipient stage, then stage of immature senile cataract when the lens is partially opacified, then stage of mature cataract or white cataract when it is totally opacified, and the final stage of hypermaturity. Now in the hypermaturity, the two kind of changes they can happen. The lens can develop what is known as Morgagninian cataract. Now in Morgagninian cataract, what happens? The cortical part of the lens becomes liquefied and the nuclear part, not the lens, please correct us here, the nucleus part sinks down and the liquefied cortex leaks through the lens capsule. Okay, I will just show you the figure, you will understand better, but read the points at the moment. One type of hypermature cataract can be Morgagninian cataract, in which the cortical matter becomes liquefied, the nucleus sinks down, and the cortex leaks through the lens capsule. Okay. Whereas the second type, it can become sclerotic type of hypermature cataract, in which the lens shrinks in size. Okay. It, rather than becoming liquefied, it shrinks in size. So shrinkage of the lens occurs. The capsule cannot shrink. So there is wrinkling of the capsule, and the zonules which were holding the lens, they become weak. Now this kind of the lens becomes unstable. This kind of the lens becomes unstable. That is the sclerotic type of the hypermature cataract. Now let me show you some figures which will help you, some images which will help you understand how these cataracts they look like. So first of all, have a look at the figure 9.12 beta. This is your mature cataract or total white cataract. This is total white cataract. Are you having the look at this figure, total white cataract? So you can see here the whole of the cataract, the lens has become opacified. it is total cataract. So this is the mature cataract. Okay. So first, now let's concentrate only on the figures here. The second, coming to the figure 9.13. This is your Morgagnonian cataract. So you see the upper part is the liquefied cortex. The upper part is the liquefied cortex. The nucleus has sunk down. The nucleus has sunken down. So this is what happens in Morgagnonian cataract. Okay. And coming to the figure below, this is your sclerotic hypermature cataract. The lens shrinks in size. The capsule has become wrinkled. Sclerotic means it is shrinking. The capsule has become wrinkled. And this kind of lens becomes unstable and it can dislocate or subluxate from its position. Okay, so it does not remain its position. It can dislocate or subluxate. So that is the complication of sclerotic hypermature cataract. Okay, so the coming back to the theory which we had written here, come back to this page here, that mature cataract, total white, hypermature, it can get converted into Morgagnonian cataract or it can get converted into sclerotic cataract, right? Now, then coming here, what I have written, phacolytic glaucoma or phacoanaphylaxis. Okay. Now, I would suggest you that rather than, you can just ignore this heading here. You can cut it out. I'll make you write. That will be better. You can cut the heading, what is mentioned as phacolytic glaucoma or phacoanaphylaxis. Let's write it down. That will be better. Okay. So come to this page only better where Morgagnonian cataract is there and this space is there to write. Now, as I told you, in Morgagnonian cataract, you can mark an arrow so that you know you are talking about Morgagnonian cataract. Now, what happens in Morgagnonian cataract? The cortical matter leaks out from lens capsule. Okay, so please write it down so that you know for your notes there. Mark an arrow for the Morgagnonian cataract. So what is happening in Morgagnonian cataract? The cortical matter, the liquefied cortical matter leaks out from the lens capsule. So it can cause, now when this matter leaks out, it comes into the anterior chamber. Okay, it comes into the anterior chamber. So it can block the trabecular meshwork. It can block the trabecular meshwork and it leads to phacolytic glaucoma. It leads to phacolytic glaucoma. So here I just want you to write what is phacolytic glaucoma, what is trabecular meshwork. I'm going to explain in glaucoma chapter, but completes your notes here because this can be asked as a question, that what is the complication of Morgagnonian cataract. Okay, so this is a complication of Morgagnonian cataract. What is Morgagnonian cataract? I have told you. What is the complication of Morgagnonian cataract? That is phacolytic glaucoma. What is happening in this? The liquefied cortical matter leaks out from the lens capsule It blocks the trabecular meshwork, which causes phacolytic glaucoma. Okay. The more I will explain you in the chapter of glaucoma, but at this point of time, please write it down. So you have to remember phacolytic glaucoma is the complication of Morgagnian cataract. Okay. So this can be Morgagnian cataract. Image can also come. So image question can also come. So you can identify upper white part, the liquefied cataract, and below sunken lens there. Okay, beta? Right? And what is the complication of sclerotic hypermature cataract? Dislocation or subluxation of the lens. Dislocation or subluxation of the lens. Okay, because it has become shrunken, it has become unstable. It has become unstable. Okay, is that fine? Okay, now we move to another condition which is known as intumescent cataract. Intumescent cataract. Okay, so first look at this figure and then we will go ahead. What does intumescent means? Intumescent means swollen. Intumescent means swollen. Now what happens when mature cataract, becomes swollen, it is called intumescent cataract. The white mature cataract becomes further swollen, then it is called intumescent cataract. Now this swollen cataract again causes a type of glaucoma. You see how the cataract is pushing, it's kind of bulging out. Because it is swollen, it is bulging out. Now, when it is bulging out, it again causes increased pressure of the eye and glaucoma. So this type of glaucoma is called, come down, phacomorphic glaucoma. The Morgagnian I told you, phacolytic. So don't confuse Morgagnian, phacolytic. This is phacomorphic. So what is happening? Because mature cataract becomes more swollen, hydrated and swollen, that is intumescent. So that pushes the lens iris diaphragm forward, due to which intraocular pressure increases, and that causes phacomorphic glaucoma. So this again is a question that what causes phacomorphic glaucoma? Intumescent mature cataract. Intumescent mature cataract. Okay. So we'll talk about glaucoma. You will understand how the pressure is increasing. But at this point of time, remember, the swollen mature cataract causes phacomorphic glaucoma. Okay. And if I summarize, if you want to write like, summary point based upon what we just did to understand from the question point of view, okay, from the exam point of view. So you can mark it here that how the question can come. Number one, the question can be, so this is a kind of summary, phacolytic glaucoma. Write down, just it's a repetition, but it will be a good summary for you. Phacolytic glaucoma is caused by Morgagnian cataract. So this will summarize, beta. You can write it down in the space here. Phacolytic glaucoma is caused by Morgagnian cataract. Phacomorphic glaucoma. Phacomorphic glaucoma is caused by intumescent intumescent mature cataract. Okay, so these 2 points, they can be asked as questions. So this is the summary here. Phacolytic glaucoma is caused by Morgagnonian cataract, and phacomorphic glaucoma is caused by intumescent mature cataract. Okay, right? Okay. So this was like, we discussed different type of senile cataract, different stages of maturity, then hypermature cataract, and what complication they can cause. Okay. Now, moving on to the next topic, there can be other causes of the acquired cataract also. Okay, there can be other causes of acquired cataract also. What we did so far was age related senile cataract. What can be other causes of the acquired cataract? So there can be multiple reasons which can cause cataract. So I have listed them here. The cataract can be caused by trauma. The cataract can be caused by various metabolic conditions. For example, diabetes and other diseases. I'm going to tell you which there. So this is just for example, diabetes. Then one type of the cataract is called complicated cataract. I will just tell you what is complicated cataract. The various toxins or drugs, they can cause cataract. And sometimes the cataract changes, they occur before age. And there is no other reason. That is called pre-senile cataract. Okay. So this is the list of what all can cause cataract. So cataract can be caused by trauma, different type of trauma, injury to the lens. It can be caused by various metabolic diseases. Then there is one type known as complicated cataract. Then it can be caused by toxins or drugs. And sometimes the cataract changes, they appear before the senile age, but there is no other reason. We call it as pre-senile cataract. Now let's go through some important cataracts, why they are happening, how they look like. Okay, so in this category, the question will be the association of the cause, that why it is happening, and what is the type of cataract which develops in these cases. Okay, beta, right? So first of all, let me tell you about traumatic cataract. Now, trauma can be in different forms. Okay, it is not just that somebody is kind of punching you. The trauma to the lens or injury to the lens can be caused by different things. So, for example, radiation. Exposure to radiation can cause injury to the lens. The lens is most radiosensitive part of the eye. So if a person is exposed to the radiation, the cataract can develop. And the radiation related cataract, which type of cataract develops? Posterior subcapsular. Okay. So now, I want you to make a point in your mind. When I talk about posterior subcapsular, it is a type of morphology. Okay. It is the type of the morphology of the lens. So you will see many type of the causes. They can cause posterior subcapsular cataract because it is type of morphology. It is not one single thing. Okay. So we have already read that age-related cataract can appear as posterior subcapsular cataract. But there can be other causes which also cause similar type of cataract. It is a morphological type of the cataract. Okay, you got my point, bache? Okay, so if there is a radiation-related cataract, that is also posterior subcapsular in appearance. Similarly, thermal injury, high heat, it can cause cataract. Okay. So high heat can cause cataract. It is also posterior subcapsular type. And what are the condition in which a person is exposed to very high heat? For example, the people working in glass factories. So where glass and glass objects are made, the very high temperatures are used there. So that can cause thermal injury to the lens. And this type of cataract is also known as glass blower. The people who work as glass blower, so because of the high temperature, they develop the cataract. And the type of cataract which they develop is posterior subcapsular. Okay. Then another thing which can happen due to thermal injury, the lens capsule can become exfoliated. That so much of high temperature is there, the lens capsule becomes exfoliation of the lens capsule occurs. Okay. So this can happen when there is thermal injury or high temperature injury to the lens. Development of posterior subcapsular cataract and true exfoliation of the lens capsule. The lens capsule becomes exfoliated. Okay. Then electrical injury, when a person gets electrical shock or there is lightning injury, then again cataract can develop. And this type of the cataract is anterior subcapsular. This type of the cataract is anterior subcapsular. Okay. So please remember this because all of this can come as one-liner question. All of this can come as one-liner question. That is radiation related cataract causes posterior subcapsular cataract. Okay. The glass blower cataract is posterior subcapsular cataract. The electrical injury is anterior subcapsular cataract. Okay. Right. Okay. Right. Now, moving on to another type of the cataract which we see in trauma, that is called rosette cataract. That is called rosette cataract. Now, rosette cataract is seen when there is blunt trauma. When there is blunt trauma. Blunt trauma means like, somebody punches your eye or a ball hit your eye. That is blunt trauma. Okay. Now, in the blunt trauma, the specific type of the cataract which is seen is called rosette cataract. Now, this can be asked as image question. This can be asked as image question. That they tell you that there was a history, a person was hit on the eye by a football or by a cricket ball, and this is seen on the slit lamp examination. Identify the type of the cataract. So as you can see, the opacity is in the form of like a rosette flower. So this is called rosette cataract. So you can identify from the shape of the cataract, shape of the opacity, rosette cataract. The second sign which is seen in the blunt trauma is called Vossius ring. Vossius ring. Now, what is Vossius ring? The Vossius ring is like, brown pigment on the lens capsule. The Vossius ring. This is Vossius ring. Vossius ring is, you can write it also, the brown pigment on lens capsule. Now it occurs because when there, something hits the eye, the pupil touches the lens and it leaves the brown pigment there. So that is known as Vossius ring. So this also has been asked as a question. So these three things, blunt trauma can cause rosette cataract and Vossius ring. So these three things, they will come together. Blunt trauma can cause rosette cataract and appearance of osseous ring. Okay. So, and image-based questions. So this, remember this, blunt trauma associated with rosette cataract and associated with osseous ring. Fine, beta? Then if there is penetrating trauma, so this is a different heading actually. If there is penetrating trauma, penetrating means the perforating injury, like a needle hits the eye or some sharp object hits the eye. That is penetrating trauma. In that case, it will be directly touching the interior part of the lens. So the type of cataract which develops will be either anterior capsular or anterior subcapsular. It will be either anterior capsular or anterior subcapsular. Okay, right? Fine. So this was the different type of the trauma-related cataract. Radiation trauma, thermal injury, electrical injury, blunt trauma, penetrating trauma. Okay. Then coming on to the next category, which can cause cataract, what we call as metabolic cataract. Metabolic cataract. Now, as I told you, different metabolic conditions, they can cause cataract. And the three common ones are your diabetes, condition called galactosemia, and Wilson's disease. So these three are important to know about the metabolic cataract: diabetes, galactosemia, and Wilson's disease. Okay. Now, first of all, let's make a heading. Forget this point here. We are going to talk about diabetic cataract. Make a heading here, diabetic cataract. Okay. Make a heading here, beta, diabetic cataract. Now, why a diabetic person develops cataract? Okay. Now, what happens in diabetes when there is excess blood glucose? When there is excess blood glucose, that is converted into sorbitol by the enzyme aldose reductase. The excess glucose in the body is converted into sorbitol by aldose reductase enzyme. Now this sorbitol, it accumulates in the lens and it causes hydration of the lens. Okay. So when there is uncontrolled diabetes, when there is increased blood glucose, the excess glucose is converted into sorbitol by the aldose reductase enzyme. This sorbitol accumulates in the lens and it causes hydration of the lens. That leads to diabetic cataract, and this type of the cataract is called snowflake cataract. Snowflake cataract. Okay, and this is how the snowflake cataract looks like. So you can see the snowflake. So snowflake cataract. So this happens when there is uncontrolled blood sugar. Especially it is more common in type 1 diabetes. Especially it is more common in type 1 diabetes because more chances of very uncontrolled high blood sugar levels. This, another thing which you see here is the patient will have a fluctuating refractive error. The patient has fluctuating refractive error. Okay. So these are the features which happens in diabetic cataract. Then there is another thing. This is not the only type of cataract you will see in diabetes, because the diabetic people, they can have age-related cataract also, which is usually nuclear sclerosis type. Okay. So what I mean to say is that it is not that every diabetic person is going to develop snowflake cataract only. No. Some diabetics in which the blood sugar is very high acutely, they develop snowflake cataract. Otherwise, most of them, they develop age-related cataract, nuclear sclerosis type. Okay. But in your exam, if they are going to ask that the snowflake cataract is seen in which condition? So yes, this is seen in diabetic conditions. Okay. And even the question they have been asked about the mechanism, that how this snowflake cataract is developing. So you can tell the snowflake cataract is developing because the excess glucose is converted into sorbitol, which causes hydration of the lens, Okay, right? Then coming to another metabolic condition which can cause cataract is your galactosemia. Okay. So galactosemia causes, as you are seeing a figure here, oil droplet cataract. So you can write here also, it is written below also, oil droplet cataract. Please write it down. Galactosemia, this image is being shown to you. This image is shown to you. It is oil droplet cataract, which is a feature of galactosemia. Okay. So come down here and let me tell you a little bit more about the oil droplet cataract. Now, what happens in galactosemia? There is deficiency of the enzyme galactose 1-phosphate uridyl transferase, due to which there is excess galactose in the body. The body is not able to metabolize the galactose. So that leads to oil droplet cataract. But oil droplet cataract in galactosemia can be reversible if you correct the galactosemia. And how the galactosemia is corrected? You put the patient on the specific diet, isn't it? Right? So galactosemia, which causes oil droplet cataract, why it is happening? So this can be asked as a question. As I told you, all these, they can come as one-liner questions. Okay. They can come as one-liner question, that how the cataract is developing and which type of the cataract is developing. So in galactosemia, which type of the cataract is developing? Oil droplet cataract. Why it is developing? Because there is deficiency of the enzyme galactose 1-phosphate uridyl transferase. This cataract is a reversible type of cataract. If you correct galactosemia, it may reverse also. Okay, right? Then coming to the third type of the metabolic cataract, which is your sunflower cataract, which is seen in Wilson disease. So yesterday also we talked about, today itself we talked about Wilson's disease. So Wilson's disease is a disease in which there is deposition of copper. Okay. So in the eye, the Wilson's disease can cause Kayser-Fleischer ring, as I told you in the morning, and it can also lead to a type of cataract which is known as sunflower cataract. You see the typical appearance of the sunflower cataract. So again, this can be your question, that what is the type of the cataract seen in Wilson's disease? That is sunflower cataract. Okay, so one-liner question about Wilson's disease. KF ring we already discussed. The second thing is development of sunflower cataract, which is due to copper deposition. Okay, so three metabolic condition: diabetes, galactosemia, and Wilson's disease. They cause specific type of cataract in the eye. Okay, fine, right. So this space is actually not needed here. You can just cut it out. There's nothing else to be written there. Now coming to the complicated cataract. Coming to the complicated cataract. Now, what do we mean by complicated cataract? Complicated cataract is also called secondary cataract. This is the type of cataract which develops secondary to some other eye disease. Okay, secondary to some other eye disease. So please write it down. The development of cataract secondary to other eye disease is known as complicated cataract or secondary cataract. Development of cataract secondary to other eye disease is called complicated cataract. And which eye diseases can cause complicated cataract? The four are most common: uveitis, high myopia, retinitis pigmentosa, and acute angle closure glaucoma. These are the four conditions. These are the four conditions which can cause complicated cataract: uveitis, high myopia, retinitis pigmentosa, and acute angle closure glaucoma. Now, out of these, the first three, make this bracket as a single bracket. Make this bracket as a single bracket. The first three, the type of the cataract which is caused is posterior subcapsular type. The type of the cataract which is caused is posterior subcapsular type. Okay, so let me tell you something more here. So this is how, first you come to this figure. This is how the complicated cataract looks like. So it is a posterior subcapsular type. So as you can see, this is the anterior part. This is the anterior part of the lens. This is the posterior part of the lens. And you see the opacity here. So it is a type of posterior subcapsular. Okay. But it has two special features. It has two special features. One is what is called breadcrumb-like appearance. You must have seen the small breadcrumb pieces. So it appears like brittle-like breadcrumb. And it has a specific luster, which is called polychromatic luster. So you can see the shiny luster. So these two are the special features of complicated cataract. So this again is an important point, and this has been asked as the question also. Please mark it as a high yield point and a question. Okay. So posterior subcapsular cataract, seen when it is as a complicated cataract, has two special appearances. We call it as breadcrumb appearance and polychromatic luster. Okay, so this type of complicated cataract is seen in these three conditions, as I told you: uveitis, high myopia, and retinitis pigmentosa. So they produce complicated cataract, which is having breadcrumb appearance and polychromatic luster. Okay, but what happens in acute angle closure glaucoma? In acute angle closure glaucoma, the cataract is little different. It is what is known as glaucoma flaccen because it is anterior lens opacity. Okay, so acute in glaucoma, when the complicated cataract occurs, it is called glaucoma flaccen. The complicated cataract caused in glaucoma is which type of glaucoma? Angle closure glaucoma is called glaucoma flaccen, and it is not posterior subcapsular, it is anterior lens opacity. Okay, beta? So it is clear. So in complicated cataract, you must know what is the meaning of complicated cataract. The meaning of complicated cataract means when the cataract is developing secondary to some other eye disease. Okay. Then second, what are the causes? There are 4 causes, out of which first 3, uveitis, high myopia, retinitis pigmentosa, they produce posterior subcapsular type cataract. And this cataract has special appearance, breadcrumb appearance and polychromatic luster. But when it is complicated cataract due to angle closure glaucoma, the type of the cataract is glaucoma flaccen or anterior lens opacity. Okay, right? So all these points, they can come as your questions, beta. Fine. Okay, then just 2 more things before we take the lunch break. Okay, there is a figure here for you, figure 9.21. Figure 9.21. Okay, so this figure is telling you about myotonic dystrophy. The type of the cataract which you are seeing here is Christmas tree cataract. Christmas tree cataract. Okay, so this is the appearance, like, you know, a shining Christmas tree. So this is your Christmas tree cataract, which is seen in myotonic dystrophy. So myotonic dystrophy, the disease can have the Christmas tree cataract. This is again your one-liner question there. Your one-liner question there. Okay. Right? Okay. Then in the types of cataract, the last type I want you to know is drug-induced cataract. Now, many drugs, they can cause the cataract. The lot of drugs, they can, when they are given for longer period of time, they can cause the cataract. Now, this drug-induced cataract can be either posterior subcapsular or anterior subcapsular. Okay? The drugs which cause posterior subcapsular cataract, most important is your systemic corticosteroids. Systemic corticosteroids. Okay, so this is most important to know. Besides this, busulfan and chloroquine, they also cause posterior subcapsular cataract. Many other drugs, they cause anterior subcapsular cataract, and it includes amiodarone, allopurinol, chlorpromazine, gold salts, anticholinergic like ecothiopate. So ecothiopate is an example of anticholinergic. Okay. So if you cannot remember all of them, please remember 2 important points as I told you. The steroids. The steroids, they cause posterior subcapsular cataract, and the cataract caused by chlorpromazine, which is stellate shaped, like a star, stellate shaped. Okay, so please remember at least these 2 points, which can help us in our exam question, one-liner question. That is the cataract caused by corticosteroids. Corticosteroids will be posterior subcapsular, and the cataract caused by the drug chlorpromazine will be stellate shaped. Will be stellate shaped. Okay, so if you now, like, you know, if you go back and summarize everything, it seems like we have discussed so many multiple things. So actually, as I told you, what is there in this part of the chapter, that what are the different types of morphological types of cataract, what are the different conditions producing the cataract, and what type of cataract we see. Okay, so that is the summary. For example, just like, in Wilson's disease, you see sunflower cataract. In diabetes, you see snowflake cataract. Similarly, the complicated cataract is posterior subcapsular type. The onion peel appearance is seen in posterior polar cataract. So most of the time you will get one-liner questions out of this, and all those points which I told you to mark as questions, they can help you solving the one-liner questions. Okay, right? Okay. So now we will be coming to the second part of this chapter, in which we come to the management of the cataract. Okay. So few minutes before we break for the lunch, and then we can continue after the lunch. So how the patient of cataract will present to you? Why do you want to treat the cataract? Because the patient will have difficulty in vision. Now, this difficulty in the vision can be in different forms. One is that, like, the visual acuity is decreased, that you cannot see the smaller things. It can be glare. As I told you, glare means scattering of light. You must have experienced sometimes when some bright light comes, though your vision is normal, but you feel so much of scattering of light as if you are not able to see anything. So patient can complain of glare or scattering of light. The patient can complain of colored halos, as I told you in the early stages of cataract. The patient can complain of doubling of the vision due to cataract. So patient can come with multiple problems, and you diagnose the patient as cataract, and now you have to manage this patient. So what is the management of cataract? See, the only management of the cataract is surgical management. There is no medicine or no other treatment. When the cataract reaches a significant stage where it is causing vision problem to the patient, you have to manage the cataract. And what we do in the surgical management, you remove the cataractous lens and you replace it by an implant. Okay, so you can write here for your reference what is basically principally done in the surgical management of cataract. That is removal of cataractous lens, and intraocular lens implantation. Okay. Now this intraocular lens, the short form is called IOL. The short form is called IOL. So you remove the lens, which was the natural lens in the eye, but has become opacified, cataractous, and you are now going to replace it with an implant, which is intraocular lens. Okay, so this is we are going to do as a second part of the chapter. After the lunch, we can break over here and then continue with the management of the cataract after your lunch break. Okay, is that all right? So we go ahead and break for 45 minutes. So it is 1 o'clock and I see you back at 1:45 to continue with the rest of our session here. Okay, so lunch break, friends. And see you at 1:45. Right? Okay. Enjoy your lunch, take a break, refresh yourself, and come back.